A very good morning to beautiful people. WHO has launched campaign Code Blue during the past week to save our antibiotics, and we all have gathered here to do our part. And this is the most urgent and most noble need for the world right now. So I invite Professor Sanjay Vikrant, our Dean, to inaugurate this session.
Good morning to all of you. I would like to welcome you all for this online CME on establishing antimicrobial stewardship, a roadmap by the experts. As you know, that antimicrobial resistance is a crisis that leads to increase in infection rate, leading to increase in morbidity and mortality. But it is a crisis that can be avoided provided we take swift and quick action in the right direction. Antimicrobial stewardship is one such step in this path to fight antimicrobial resistance and achieve quality care. Recently, Government of India and Ministry of Health and Family Welfare had issued an advisory regarding establishing antimicrobial stewardship in every institute. Aiims Bilaspur, which is still in its infancy state and is proposed to be a 750 bedded hospital with 15 to 20 super specialty department, pledges to carry forward this mandate so that antimicrobial resistance, antimicrobial stewardship becomes an integral part of this institute right from its inception. We will begin our OPD services in the first week of December, and I urge all clinicians to comply with the guidelines of antimicrobial stewardship. I congratulate Department of Microbiology, Aiims Bilaspur, for organizing this very essential and much needed CME, which will help it forward in enriching the medical fraternity across all specialties. And I hope you will apply this roadmap in your respective institutes. I wish the very best to all of you. Thanks.
So we begin with our session one, and our first speaker of the morning is Dr. Megha Sharma. She's a budding microbiologist and assistant professor in our department, and she has won several gold medals, that is VK Bhargav Gold Medal for Best MD Student at PGI Chandigarh, and President's Gold Medal for DMB Microbiology. And she has several international publications, more than 50 to her credit, and I invite Dr. Megha to enlighten us.
Thank you, ma'am, for the kind words. A very good morning to all the delegates who have joined us from across the country. I'm Dr. Megha Sharma, working as Assistant Professor in the Department of Microbiology at Aiims Bilaspur. The topic for my talk in this CME on establishing antimicrobial stewardship is antibiotics at a glance. Now, before I take you to antibiotics proper, let me give you a snapshot of the brief history. Antibiotics were earlier called the magic bullets, a term given by Paul Ehrlich to the drug that he discovered for syphilis, Selbarsen. Even as early as 1820, quinine, obtained from the bark of the cinchona tree, was used to treat malaria, and sulfonamides were available even in 1930s. The term antibiotic, in the original sense of the word, was used for the first time for penicillin, to denote a formulation which is derived from a living organism and that kills another organism. But with time, even the synthetic compounds, either partially or wholly, were this term was being used for them also. Antibiotic, antimicrobial being used interchangeably. Now, it was Ernest Duchenne, a French physician, who first noted that a mold could kill bacteria. That mold was penicillium itself. However, his work remained unnoticed, and it was only 32 years later that the same thing was rediscovered by Alexander Fleming. Now, Fleming discovered that penicillin killed bacteria, and he made two important proclamations. The first was, Fleming was convinced that this observation could never lead to therapeutic agents, and expressed his concern about the improper use of penicillin and how easily resistance could develop if used in insufficient dosage. Now, fortunately, his first proclamation became false. It was the work of Florey and Chain who resurrected his work and started producing penicillin on a wide scale, which actually changed the course of the World War II. His second proclamation, however, unfortunately came true. And it was in his acceptance speech of 1945, where, while receiving his Nobel Prize, he warned that resistance will follow soon. Now, ever since the discovery of penicillin and its use on a commercial level, there has been a boom in the industry of antibiotics. Now, this particular time period, say from 1940s to 1970s, was termed as the golden age of antibiotics. Several new classes, over 20 of them, were discovered during this period. This was followed by a gap wherein some of the organisms developed resistance to some drugs, but again, about 60 more antibiotics were released to the market. And then there came a discovery void, so much so that now we are left with organisms that are hardly susceptible to any of the available drugs. Even the last resort drug, colistin, has now developed resistance. And it is projected that by 2050, it will be the antimicrobial resistance which will be the greatest killer in the world. Now, resistance follows the drug like a faithful shadow, much like what Fleming had predicted. As you can see, deployment of sulfonamides, resistance of sulfonamides. Deployment of penicillin followed soon by its resistance. Deployment of vancomycin, okay, a gap of a few years, but again the resistance came up. So on and so forth. So there are three important challenges that the world is facing now. The first is that we have a near empty pipeline. There's a discovery void. And we do not have any new drugs to look forward to. Then there are low approvals. Here you can see that over these years in the United States, as compared to antibiotics, it was the cancer drugs which increased there were increase in the approvals of cancer drugs, whereas antibiotics were lagging behind. And even in the approved antibiotics, the companies producing them, they declared bankruptcy. So there are low approvals for antibiotics. And the third is the impending threat that the antimicrobial resistance will be the biggest killer. So what option do we have? Facing these challenges, the only option left with us is whatever we have in our hand right now, we have to use it very smartly, very cautiously. Now, this is the classification of antibiotics that I'll be using in my presentation. The antibiotics can be classified in various ways, depending on their mechanism of action, depending on their pharmacokinetics, time dependency, concentration dependency. But this is the most commonly used classification based on the chemical structure. Now, I'll be glancing you all through the different antibiotic classes, and not in terms of pharmacology, but in terms of stewardship. That is, we will discuss what is their spectrum of action, where they should be used, and rather where they should not be used. So let's go on. The first class is that of sulfonamides. The sulfonamide trimethoprim, also called the cotrimoxazole. Now, it is used in many of the infections like urinary tract infection, chronic or recurrent, respiratory infection, bloodstream infections, skin and soft tissue infections, but obviously only when a susceptible organism is there. Now, the range of susceptibility of cotrimoxazole is quite narrow. It is varied but narrow. So they are drug of choice for pneumocystis jirovecii. We know that. They're also used in the prophylaxis in AIDS patients. Other than that, among the gram-positives, they cover MRSA, they cover nocardia, they cover bordetella. And in the gram-negatives, they are important antibiotics against non-fermenting. Now, these are the notorious gram-negative bacilli, which do not respond to most of the usual drugs. So cotrimoxazole here is an important salvage therapy. They're important drugs against brucella, but they do not have any anaerobic coverage. Then comes the class of quinolones. They're also used in a wide range of infections. So let us see what these quinolones are. So there are the 4 generations, the first being the nalidixic acid, and the subsequent one being the fluoroquinolones. Now, the spectrum of action of the first generation is limited only to the gram-negative pathogens, that too only the Enterobacteriaceae. But the spectrum of action of the subsequent generations contain a lot many gram-negatives beyond Enterobacteriaceae. They cover Pseudomonas, they cover Haemophilus, they cover atypical organisms like Chlamydophila, Mycoplasma, and they also cover non-fermenting gram-negative organisms. Now, fluoroquinolones are active against mycobacterial species also and against the non-tubercular mycobacteria. But the gram-positive coverage is not that wide. The second generations are active only against MSSA, the methicillin-sensitive Staphylococcus aureus. But the third generation, the subsequent 4th generation, offers a greater spectrum. That is the methicillin-sensitive Staph aureus, community-acquired MRSA, coagulase-negative Staph, and even Strep pneumoniae. And the 4th generation also offers coverage against anaerobes. Now, a word of caution here, that in a country like India, where tuberculosis is so endemic and is rapidly developing resistance to the conventional antitubercular therapy, it is very prudent that quinolones should be restricted in use. They should be used very judiciously so as to safeguard them for the treatment of tuberculosis. Then there comes tetracycline and chloramphenicol. They are typically called the wide spectrum drugs. So tetracycline cover most of the gram-positive, many gram-negatives, and even anaerobes. They cover atypical organisms like Rickettsia, Mycoplasma, Chlamydia, Brucella, and also H. pylori. Even chloramphenicol is a broad-spectrum antibiotic. It covers gram-positives, gram-negatives, Rickettsia, Mycoplasma, even Salmonella, and it has an anaerobic coverage against many anaerobes, including bacteroides. Now there comes the most important class, the beta-lactams. Now, to simplify this, let's see. The beta-lactams consist of these 4 subclasses under them: the penicillins, the cephalosporins, the monobactam, and the carbapenems. Now, the penicillins. Among the penicillins that are active against Staphylococcus, now here we are talking about methicillin-sensitive Staphylococcus. We have oxacillin, nafcillin, dicloxacillin, and then there are certain penicillins in combination with tazobactam or clavulanic acid also have activity against Pseudomonas. Then there are the generations of cephalosporins. With an increase in generation, there's an increasing gram-negative coverage. However, the 5th generation has MRSA coverage also. Now, importantly, beyond the 3rd generation, that is drugs like ceftazidime and cefepime, they have good activity against Pseudomonas also. And these drugs, when used in combination with beta-lactamase inhibitors like tazobactam or avibactam, have good activity against ESBL-producing organisms and even carbapenem-resistant organisms. Now, monobactam consists of a drug called astronam. This particular drug has activity only against aerobic gram-negatives and Pseudomonas, but not against gram-positive and anaerobes. Though it is restricted, do remember this name, as it will be coming later up in the presentation today to salvages somewhere. And then there are the carbapenems: imipenem, meropenem, doripenem. Now, these drugs are active against ESBLs, against Pseudomonas, even against anaerobes. So while using them, there's no point in giving an extra anaerobic coverage. Now, the next group of drugs are the macrolides. The main important agents under that are erythromycin, azithromycin, and clarithromycin. Now, just looking at these boxes, we'll be fascinated that it has such a wide spectrum. No wonder. This is why they are used left, right, and central. But are they really indicated for all these organisms? No. The only indication for macrolides, they are the drug of choice for only these particular infections, namely chlamydia, Chlamydia trachomatis, Chlamydophila pneumoniae, Mycoplasma pneumoniae, Bordetella pertussis, Bartonella, quadruple therapy in H. pylori, non-gonococcal urethritis, and non-tubercular mycobacteria like avium, abscessus, and fortutum. For everything else, they are only an alternative drug. Now, unfortunately, there have not been enough guidelines to support or refute the use of macrolides, especially in respiratory infections where they are widely used. However, I found out a few of them. Now, it was the Polish expert group that came up with their guidelines in 2016 for upper respiratory tract infection, both in pediatric and adult population. As you can see, these guidelines clearly state, and I'm so happy that they do so, that macrolides are only an alternative drug. Be it acute pharyngitis or tonsillitis, be it acute otitis media, be it acute rhinosinusitis also. They are to be used only and only if there's a hypersensitivity to beta-lactam. So first drug of choice remains the beta-lactam. However, these guidelines advise that macrolides can be used as the first-line therapy if mycoplasma is suspected, chlamydophila is suspected, or it is Haemophilus influenza, provided there are microbiological evidences for these infections. And the only one upper respiratory tract infection where they do recommend long-term macrolide is the chronic rhinosinusitis, that too only in adults. In pediatric, they have no role. Now, coming on to the lower respiratory tract infections. Recently, two important guidelines have come up. One by the British Thoracic Society and the other by the Indian Society, published in Lung India this year. Now, there are certain differences among the two guidelines. Now, first of all, in cases of COPD, widely prevalent, both in Britain as well as in India, the guidelines are more or less same. They say that macrolides can be used or should be used only in cases of COPD patients having frequent exacerbations. Now, by frequent, they means more than 3 exacerbations in a year. The Indian guidelines, however, have gone a step further and have given a word of caution that we should be vigilant for the resistance against macrolides if the patient is not responding or this increased frequency of exacerbation. Then regarding asthma and bronchiectasis exacerbation, there's a difference in opinion. While the British guidelines, they promote or recommend the use of macrolides as the first-line therapy, the Indian guidelines tell that you have to use them only in select patients. For asthma, for patients presenting with asthma-like features in India, first you have to rule out an infection by non-tubercular mycobacteria or even resistance to macrolides if not responding. And for patients presenting with bronchiectasis-like picture, you have to rule out Pseudomonas because their macrolides will not work properly. In case of bronchiolitis obliterans, both the societies have almost similar recommendation. While the Indian ones say that macrolides have no role, the British ones also say that macrolides can be given only in lung transplant patients having suspected infection by atypical organisms. And in case of unexplained cough or organizing pneumonia, many a times here the macrolides are being given, but the recommendations do not say so. They have not addressed this particular issue. However, the British Thoracic Society guidelines, they say that they have no role. Macrolides should not be given. Now, coming on to the next 5 or 6 groups of antibiotics, simply through this diagram. Now, why I've chosen this diagram is that not only covers the major classes of the antibiotics, but it covers them in such a way that we can see the overlapping. So we know what is the spectrum of each antibiotic and where a combination should not be used at all. So let's see. The aminoglycosides, gentamicin, tobramycin, they're active against MRSA, they're active against MSSA, and even enterococcus, and they're active against a wide range of gram negatives. But aminoglycosides should mostly be used in combination. And then there are lincosamide. The very important agent in this class is clindamycin. Clindamycin is largely underrated. So clindamycin is active against MRSA, MSSA, and importantly, it has good coverage for streptococcus and even anaerobes. So in conditions we are suspecting a mixed infection, by the gram-positive cocaine, even anaerobes, clindamycin will do the job, and there's no need for an extra anaerobic coverage. Then there are glycopeptides, vancomycin, teicoplanin. These drugs have activity against MRSA and even against certain anaerobes. Now, it is important to remember that vancomycin is good against MRSA, but it is not that good against MSSA, the methicillin-sensitive Staph aureus, where it should be avoided. The next class of drugs is the polypeptides. Now, the polypeptides or the polymyxins, they consist of two main drugs, the polymyxin B and the polymyxin E, which is commonly called colistin. Now, these two drugs have cross resistance. That is, if an isolate is resistant to colistin, it is resistant to polymyxin B. And if it is susceptible to colistin, it will be susceptible to polymyxin B. So no need to test for both of them. One would be sufficient. However, it is important to note that polymyxins were introduced in India in the 1960s. However, that time, there were no pharmacological studies available, and they soon went into disrepute because of their toxicities, especially renal toxicity. And it was only by the turn of the century that there was a desperate need for certain drugs which could act against the MDROs, for which no other options were available. So the polypeptides, the polymyxins, they were resurrected. And there were such desperate measures that they again didn't undergo the proper pharmacological investigations. So it is important to note that these drugs do not have any gram-positive coverage. Okay, they're active against many gram-negative organisms like multi-drug-resistant Acinetobacter species, Pseudomonas, all Enterobacteriaceae, even Stenotrophomonas maltophilia. However, among Enterobacteriaceae and other non-fermenters, there are certain organisms which are intrinsically resistant. So colistin will not work on them no matter what. These are Proteus, Morganella, Serratia, and Burkholderia. Now, there has been a debate whether polymyxin B is better or colistin is better. To answer this, let's compare them in terms of their spectrum of activity, which seems comparable. The renal clearance. While the main mechanism of excretion of colistin is via renal mechanism, polymyxin B does not go to the kidneys and hence protects them. The steady state is reached better in polymyxin B. The inter-individual variability is less, and nephrotoxicity as such is same, but indications wherein international consensus guidelines for the optimal use of polymyxins was given. Now, this particular document is endorsed by many of the societies: the American College of Clinical Pharmacy, the ECMIT, the ICSA, International Society for Anti-Infective Therapy, Society of Infectious Disease Pharmacists, all of them. Now, this particular guideline, it threw light on three very important and urgent questions regarding polymyxins. The first, how to test susceptibility of polymyxin. For nearly a decade, labs were testing polymyxins just like any other antibiotics by the disk diffusion. Simple and easy to do, easy to interpret. Even CLSI gave guidelines of disk diffusion diameter long ago. And then it was realized that these molecules are not going easily through the agar media and hence should not be tested via disk diffusion. And after a lot of controversies and a lot of discussions and deliberations, now these guidelines also, this is supported by both CLSI and UCAS, that broth microdilution using polystyrene plates are the only recommended way to test for polymyxin susceptibility. Then the question is, should one polymyxin be preferred over the other? Should we use polymyxin B or colistin? As I said in the last slide, polymyxin B could be preferred only because of its superior pharmacokinetic characteristics and less potential to cause a renal toxicity. And then there was the third most important question, whether monotherapy should be given or it should be given in combination with other drugs like carbapenem, sulbactam, etc. Now, this particular question has largely remained unresolved. So much so that even in these guidelines, to address this particular question, they mention the word that there is no consensus. They only best practice recommendations. So consensus is something based on evidence, but only based on only giving this best practice recommendation, voting was the basis. So all the experts who sat down to write these guidelines, they just did a voting 14 against 1. So it was decided that combination therapy with a drug having good activity should be preferred, but that the sister drug, the drug used in its combination should be the one which has the lowest possible MIC. So currently polymyxins are indicated only for carbapenem-resistant Acinetobacter baumannii. They can also be used in carbapenem-resistant Enterobacter and carbapenem-resistant Pseudomonas aeruginosa, provided these two are not susceptible to any other drug. So that we don't have a choice but to use colistin. But other than that, indication-wise, they are only used for CRAB. Then there are a few other drugs. Fosfomycin. It was a phosphonic acid derivative with a unique structure. It was actually a forgotten molecule recently rediscovered. Now, because of its unique structure, it has no cross resistance with other currently available drugs. And spectrum-wise, it is pretty impressive. It has a good gram-positive coverage, very good gram-negative coverage. So much so that because of these two things, a wide spectrum and no cross resistance, it was being used heavily to treat any kind of infection, to treat carbapenem-resistant Klebsiella. It is using as alternative therapy for any kind of multi-drug resistant gram-negative bacteria. But thankfully, the European Medicine Agency came up with certain indications where fosfomycin should be used, and it happened just last year. So these guidelines say that fosfomycin medicines, oral, they can be given to treat uncomplicated bladder infection in women and adolescent girls, and also in prostatitis. However, the fosfomycin by infusion should be used only to treat serious infections when other antibiotic treatments are not suitable. So it is not a drug of inclusion, it is a drug of exclusion. First exclude that nothing else will work, and only then give fosfomycin by infusion to the susceptible organism. Other than that, it is not recommended for children under 12 years and not recommended through any other route. Orally, only for 3 conditions: uncomplicated bladder infection in women, in adolescent girls, and in prostatitis. Then there is tigecycline. It also has a wide spectrum, pretty impressive. Even include some of the anaerobes. Okay, it is intrinsically resistant to Pseudomonas and Proteus, but other than that, it covers a huge lot of organisms. And interestingly, it has a large volume of distribution. So it has a very good tissue penetration. It is indicated for complicated skin and soft tissue infections, for complicated intra-abdominal infections, especially when they are expected to be multi-organisms, including anaerobes, community-acquired bacterial pneumonia, but they are not indicated for diabetic foot and hospital-acquired or ventilator-associated pneumonia. And it is controversial to use them in bacteremia. Why? Because they have such a large volume of distribution that they hardly remain there in the blood. So serum levels are pretty low. Then there are certain new kids on the block. Let's see, especially for the gram-negatives. So these are beta-lactam drugs in combination with a beta-lactamase inhibitor, ceftolozane tazobactam and ceftazidime avibactam. They were approved in 2014 and 15 respectively for possible indications like chronic urinary tract infection, intra-abdominal infection, and HAP and VAP. Now, let's compare the two. So in this particular combination, the novel compound is ceftolozane, and here the novel compound is avibactam. This is the ceftolozane tazobactam has a better coverage against Pseudomonas, while ceftazidime avibactam has a better coverage against carbapenem-resistant Enterobacteriaceae, but none of them covers MRSA. So they can be used as carbapenem-sparing alternatives, either for Enterobacteriaceae or for Pseudomonas. But let us see what all carbapenemase do they actually cover. Now, ceftolozane tazobactam, there are 4 classes. According to Ambler classification of carbapenemases, there are 4 classes, A, B, C, and D. So ceftolozane tazobactam, it does not cover the class B, the metallo-beta-lactamase, and it also does not cover KPC. Now, KPC is the most prevalent class A carbapenemase in the world, but metallo-beta-lactamases are pretty prevalent in India. Let's see what ceftazidime avibactam has to offer. This particular drug is also effective against the three classes. However, its activity is not against the metallo-beta-lactamases, the class B, and even against the oxacillinases, the oxacarbophenamases of Acinetobacter, the activity is very poor. So, will they benefit India? Any of these two? Let's see. Now, these three are the three world maps showing the distribution of KPC producers, NDM producers, and OXA48-like producers. Let's see. So, India tops the world in terms of NDM prevalence and OXA48 prevalence. Both of them are not being covered either by this combination or by this combination. So let's see. Are there any more drugs out with these MDR GNBs? Well, recently, many of the other possible antibiotics have gained FDA approvals for gram-negative bacteria. They could be drugs alone or in combination with BLI or beta-lactamase inhibitor. However, again, the question arises, will they benefit India? With such high rates of the resistance, will any of these be helpful for us? Mainly when the main problem that we have is the metallo-beta-lactamases, class B. As many as 40 to 60% of our isolates are MBL producers, the resistant isolates. Then we have a menace of carbapenem-resistant Acinetobacter baumannii and carbapenem-resistant Pseudomonas aeruginosa. So if you see that none of these 7 or 8 drugs recently approved, they have a good coverage against these 3 agents. Well, there is one particular hope coming up in this row. Let's see. So this is cefiderocol, a new drug recently updated, and it has some activity, at least shown in this table. But what do the studies say? A recent trial judging the clinical efficacy and safety of cefiderocol suggested that its efficacy and safety for acute bacterial infection was similar to two comparator groups, one containing imipenem cilastatin and the other comparing meropenem. So no matter what is written in this table, the clinical studies show that this is offering no extra advantage than what drugs we already have. So is there any light at the end of this long tunnel for the gram negatives? Well, let's see. Astronam. Now this was the monobactam I told you to remember. So astronam in combination with the beta-lactamase inhibitor avibactam. This is one drug we can actually look forward to. Currently, it is undergoing phase 3 trials. But the best choice that we have right now was ceftazidime avibactam. Now let's see what astronam avibactam has to offer. In terms of ASBL coverage and AMC, well, both are comparable. This might have more coverage for class D and vector AC. But what about class B? The metallo-beta-lactamases, the major class causing the menace of carbapenemases in India, the class B, and co-occurrence. Any other carbapenemase, when co-occurring with MBL, becomes non-susceptible to this particular drug. So there, astronam and avibactam have a lot to offer. Then let's see if there are any new kids on the block for gram positives. So there's a pretty okay, good list for the recent approvals by the FDA or by the European Medicine Agency in recent times, belonging to different classes of drugs and indicated or active against different gram-positive organisms and different health conditions. Majorly, they have a coverage against methicillin-resistant Staph aureus and are specifically indicated in certain conditions like acute bacterial skin and skin structure infection, and some of them for community-acquired bacterial pneumonia. So to summarize, the first thing that we should realize and accept and acknowledge is that multi-drug resistant organisms are giving a tough challenge. The older therapeutic options come with significant limitations and just cannot be used like that. Ceftazidime avibactam combination offers good hope for gram-negative MTROs, but it doesn't solve the problem of NDM, especially the huge problem India is facing because of them. Astronam avibactam offers greater hope for the gram-negative MTROs, but it is pending approval and clinical trial in Indian population. Then for gram-positive organisms, multi-drug resistant organisms, there are better options, but their availability and usefulness in India is debatable. Early data is encouraging in most, but more data is required for how to optimize these tools, how to make the best use in our setting. So we can say that the drug pipeline has only a few drops to offer. But anyways, there's still hope. Now the responsibility lies on us. So we have to be very judicious, not just judicious. We have to be judicious, more judicious, and most judicious, especially when we have this particular pattern of susceptibility. So if your susceptibility pattern says the organism is susceptible, be judicious in selecting the antibiotic. If it says it is resistant, be more judicious. And if you suspect a multi-drug resistant organism, be most judicious. Antibiotics are dangerous things. Please handle them with care. Because we never know, along with these handful of drugs that we are taking in, we are somewhere unknowingly eating our own world as well. So next time, there are certain points to ponder. Before you prescribe antibiotics next time to anyone, just churn your brain and answer these few questions. Is it really required? Am I dealing with an infection? Or is it just a viral infection or just inflammation, not even infection? Will it work? What is the spectrum of activity? Will the organism be intrinsically resistant? What is the acquired resistance in my area? Has the sample been taken before antibiotic starting? And what should be the adequate dosage and duration? And finally, and most importantly, when to de-escalate, when to switch to targeted therapy, when to stop. So this all depends on the susceptibility profile and choosing of the best therapeutic option. Now, this is the only way by which we can halt or at least delay the development of resistance. So your fortune cookie for today says, it starts with you. Do your part. Be an antimicrobial steward. Thank you for patient hearing.
Thank you, Megha. That was so enlightening and so updated. And I'm sure today the quiz is going to help our participants out. Our next speaker is Professor Aarti Kapil from Aiims, Delhi. All that ma'am has been working in the field of bacteriology and hospital-associated infections. She has been awarded International Investor in 2011 for Society for Healthcare Epidemiology of America. And she has been the principal investigator for various national and international projects on antimicrobial resistance. So we are eager to hear her. I invite ma'am again, Professor Aarti Kapil.
At the outset, I must thank the team of Aiims Bilaspur and Dr. Anuradha for giving me this opportunity to speak on a very important aspect of the present problem, which is antimicrobial resistance. And I also congratulate them for organizing a very timely CME during the WHO AMR Awareness Week. It would have been really nice if I could have been there myself physically and address the audience directly. But then in the present times, we have to face whatever the challenges. And I'll try to make my talk as much interesting as possible because I know it's a great challenge to keep your attention during an online talk. So I'll be talking mainly on identifying gaps in antimicrobial stewardship program, especially in the Indian context. Now, since this is the first lecture and before coming straight to the antimicrobial stewardship program and the gaps, I'll just start with a little introduction to the topic. My objectives for the presentation is to describe the need for antimicrobial stewardship program, gaps in the Indian context, the strengths and the challenges both, the evidence available, the lessons learned by whatever evidence that we have, and the way forward. Now, we all know that the pandemic of AMR, as it is now called, is one of the biggest concerns of healthcare professionals throughout the world. It is because it has been estimated that if we are not able to contain it by 2050, AMR related mortality may surpass all other causes of mortality. Now, we know that we have limited resources, we have limited antibiotics, there are no new good molecules in the near sight. So, our strategy is to contain antimicrobial resistance, make the present antibiotics last as long as they can, which is by their judicious use. And the two important action points here are judicious antibiotic use through formulating antibiotic policy, and antimicrobial stewardship program is one of the important component of this policy, and hospital infection control. So I'll be discussing mainly the antimicrobial stewardship program. So let me also introduce a bit quickly. I know all of you know the introduction part has also dealt with it. Very quickly, for the sake of completion, reiterate what is the philosophy of antimicrobial stewardship. Optimizing clinical and healthcare outcomes, minimizing unwanted effects in terms of emergence of resistance mechanisms, selection of resistant pathogens, reducing drug toxicity, and reducing the adverse impact on patient safety. So, the antibiotic use should be able to achieve all these parameters. There are multi-pronged approach, there are many components. So I'll just project this slide. You can slowly have a look. I'll focus mainly on 2-3 things, which is anyway a part of the subsequent talks. The data collection is very important, and how you analyze your local data, which is a lecture by Dr. Pallab subsequently. Then testing and reporting at the diagnostic laboratories, which Dr. Anuradha is going to tell. The drug auditing in terms of ordering, restrictive administration is again a talk by Dr. Nusrat. Education is something which all of us are doing, and today the program that we have is an important component of this continuing education. Now, let me come straight to what are the challenges in Indian context. See, India has its own problems, demographic, social, economical. There are high rates of infectious diseases. Antibiotics are comparatively inexpensive and easily available. There is increased prevalence of resistant pathogens in almost all hospitals. There is high rates of transmission, which increases the burden of healthcare associated infections. This is compounded by inefficient public healthcare delivery system. It's a vast country and a large population. We have very little community-based data, which is the majority part of the healthcare delivery system. Inadequate immunization coverage and other preventive measures, limited capacity for diagnosis of infectious diseases, limited resources for innovation and research in antimicrobials. Although attempts are being made, but let us accept that these are some of the challenges we face in our country. It's not just this part. Even the bacteria themselves, there are some challenges which are inherent part of a bacterial nature, which we cannot prevent. Gram-negative bacteria, we all know, remain ahead of us always. There are more complex resistant mechanisms, multiple enzymes and mutations. There are complex genetic mechanisms which modify phenotypic expressions and we cannot detect by molecular method, although the rapid diagnostic methods are based mainly on the molecular techniques. Bacteria is always evolving, guidelines have to be changing, and technology has to catch up. But whatever it is, we have to convince ourselves, we have to convince the administrators as well as the clinicians to initiate the antimicrobial stewardship programs. Now, how do you do that? You have to generate some evidence to convince them, yes, it helps. So, small, well-designed interventional studies can bring out some data to convince the administrators and the clinicians. This will also help us to determine and prioritize action points that are implementable and they impact the outcomes, because otherwise there are so many things to be done to control AMR that sometimes you are not very sure, a clinician is not very sure how will it go, how will it help. There are no immediate changes or immediate outcomes, so we have to have some measurable outcomes which can indicate that it does help. So I'll share with you 2-3 studies from Aiims Delhi, which were with the Department of Medicine and Microbiology. So as a part of the ID program, which does give you some indication that yes, if it is done by active intervention, then it is possible to make a difference. So this is the effectiveness of education in antibiotic control program. And here, this was a study which had phases of various observation intervention, but briefly to show you that what was found was the appropriate antibiotic use in the pre and post interventional phase significantly became better. So it was much better. The appropriateness was already defined. I will not go into the detail right now. So it improved, as also the cost of antibiotics during the pre and post intervention, and especially this was done for sepsis, septic shock patients, severe sepsis, SIRS, because a blood culture positivity and correlating with the infection gives a little more confidence in your antibiotic decision making. So it did show a better appropriate antibiotic use as well as a reduce in the cost of antibiotics because the unnecessary antibiotics were not used. Another stewardship initiative in a unit, and in this the difference was that the observational part included all the units, while there was in one unit intervention was done, while for the others the standard of care was followed. And what you can see is that in the interventional phase, what improved? De-escalation at day 4 to 7 improved significantly. Escalation also came down in the initial 3 days, because on the day 1 to 3 you can't do much. You have to give empirical antibiotic, wait for the laboratory results. But what also improved was the IV to oral switch. So this was significant and gave confidence to the residents there that yes, they can do it if they follow all what is taught to them as a part of intervention, which is also education. Then one of the residents initiated a trainee-driven stewardship program in the medicine wards. And what you see, important finding was that the blood culture, overall the request for blood culture increased, the number of times appropriate blood cultures were done before administration of the antibiotic improved, and this also significantly improved the total blood culture positivity. So this was very helpful. Another thing that was noticed was an unnecessary anaerobic coverage by continuously talking to each other, by active intervention came down. So these are some of the components of antibiotic usage which also includes diagnosis, which also include unnecessary antifungal or anaerobic coverage, which again we have a subsequent speaker talking on antifungal coverage. So these are some of the important aspects of the stewardship program. And these studies, I can tell you, you must plan, and they don't need much of the technology. They only need a person dedicated to collect data, to give training, and you will see the difference. The other term that is coming with this, I thought I must share, is the diagnostic stewardship, in which, along with antimicrobial stewardship, diagnostic stewardship goes hand in hand. I'm sure later on during the diagnosis part of the lecture, it will be covered. But here it is also the laboratory which plays a very important part by rapid diagnostic techniques, performing rapid diagnostic tests, which help in the antimicrobial stewardship. Besides the local data where you design your empirical choices, you can in a much faster manner, you can make it more judicious. Then another initiative we took was which was all clinician based, not purely the microbiologists. And so there was ownership. So it was a lot of deliberations and meetings were held, and then mainly with the pulmonary medicine, the intensive care unit department, they came out with the guidelines for antimicrobial prescriptions in critically ill patients, and it was very useful. It covers almost all the aspects of how to use empirically and then how to modify. So some of these steps help in implementing the stewardship programs. So with all this little information that we have as now, what is the way forward? At the local level, I think that you all know that stewardship program needs a committee, which is a multidisciplinary committee. And we all know microbiologists, clinicians, ID physician, if available, intensivist, the pharmacist, the clinical pharmacologist, very important in this stewardship program. That's another thing which our country presently do not have a lot of resources, lot of personnel there, but it is required. And most important, administrator, because they are the ones who are going to ensure the implementation and give you the support system, the staff, and whatever is required for the adequate implementation. Then you implement it in a stepwise manner. Again, it's not possible to take care of all the components together. Do it in a stepwise manner, which is doable, and then determine the impact by measuring the quantifiable outcomes. So, what can be the quantifiable outcomes? As I showed you in the studies that we did, the cost to the healthcare facilities. You can collect evidence on prescribing practices. Again, I'm sure that will be covered in the subsequent lectures. Then one what is called as a low-hanging fruit is the surgical prophylaxis. So one can easily make guidelines. These can be easily followed because it's very clearly risk stratified. So surgical prophylaxis is something which you can start with, and you can see how they are being implemented. A very important one when we are talking of this, the title of the talk being in the Indian context, I think national level, I think I must also touch upon that we need a very strict regulatory framework. We need capacity building at peripheral healthcare systems, including the availability of the point of care tests. Training of healthcare professionals continuously in all guidelines you will see is something that is always mentioned and is important. Public awareness is also very important because they are important stakeholders. If they start questioning and they are aware, then many of the issues will be solved. Well, India started in 2011, this was after the NDM story. So they did come out with some of the guidelines, GARP and the ministry. But there were challenges for implementation. These were too ambitious. Regulatory framework is inadequate, as I've already told you. Most of them are based on prescriptions only needed. And then that brings us to the topic of availability of doctors at all the levels to give prescriptions. So that is also one of our limitations to implement. Lack of diagnostic tests to identify bacterial infections at the field levels, and absence of a national level data. Whatever we have right now are from tertiary care hospitals or secondary care hospitals, but they represent only a small proportion of our disease. Later on, in 2017, when UN Assembly mandated that all member countries must adapt their national policies to the WHO Global Action Plan on Antimicrobial Resistance, India signatory to that, and they prepared a national health policy which included a clause on antimicrobial resistance. This was not there earlier in our national health policy. And they also prepared a national action plan on antimicrobial resistance, and which was for 5 years, and 2021, I think at some time we have to analyze what happened. But one thing I'm telling you, people are becoming aware, and lot of education, lot of small studies are being initiated, and because there is no choice, the clinicians also realize that they've reached the end of the road. And just quickly, I'll not spend time because this is here. I just want to tell you that antimicrobial optimizing the use, which is through the AMSP, is one of the component. Education is one of the important component that we are doing now. And then there is infection control. As I told you, that's another important part of reducing transmission, thereby reducing infections, thereby reducing use of antimicrobial. Research and innovation and surveillance, strengthening the leadership. These were 6 important components. This is not directly related to stewardship program, but then in parallel for AMR containment, we had guidelines from ICMR, from Ministry of Health, Family Welfare, the One Health program, and a very important Swachh Bharat Abhiyan. But then came 2 years back the COVID pandemic. There's again increase empirical and unnecessary antimicrobial use. There was a lot of panic, lack of understanding in the beginning, didn't know much, so can't blame anyone really. So now we all have to sit back and think that what one should be. You should be more prepared for such pandemics which are viral in nature. In this situation, there was prolonged hospital stay also in severe COVID patients. Then a lot of staff, the redeployment of the stewardship teams to take care of the critical care of the COVID patients. So there was a lot of shift of all the other responsibilities to COVID care. And also it is thought that wide use of the biocidal agents, like we use a lot of disinfectant in the environments, could have been responsible for increased emergence. Lot of antibiotics were given, and slowly the studies show that the bacterial co-infections per se related to COVID were not very high. There were some secondary bacterial infections because there was ICU, they were all, patients were ventilated, sampling was less, there was more scare, and so there were hardly any tests done to establish bacterial infection, and so empirical antibiotic was being used. So despite a low rate of bacterial co-infections and superinfections, more than 70% received antibiotics, which was seen in many studies. But still, I say we don't lose heart. India has shown a way in many other situations where a national level programs were successful. IMNCI for diarrheal diseases and ARTI gives clear-cut guidelines when or when not to use antibiotics. We know that antivirals restricted sale of oseltamivir during H1N1 was a success story. Then RNTCP for antitubercular drug also has a control. Antiretroviral for HIV under NACO has been able to establish a very good network, so it is possible. We also have biomedical waste management rules which everybody is following. So it's not that the will is not there or the knowledge or the professionalism is not there. So I think if we need to do, we can do. H1 schedule of drugs was one success story. Then red line for antibiotics. So if you increase public awareness, then people will ask the chemists that, no, you don't give us this, or the chemist will ensure that there is a prescription for antibiotics. So look out for the red line was also a successful campaign. India, the strength is we have a large pool of professionals, large strength of trained manpower, of medical microbiologists, which is again not so in many parts of the world. The lab infrastructure is there. Labs are coming forward for NABL accreditation in the private labs. Hospitals are getting accredited by NABH. IDSP is strengthening microbiology labs at the peripheral levels. So once that is there, we'll have more microbiology-based diagnosis and use of antibiotics based upon the bacterial etiologies. Research is also being promoted by various government agencies, and so we can together move forward and meet this challenge by fighting it all together. In the end, I'll just thank by reiterating that how for as a catchy the blue go blue campaign by WHO is has been recommended or has been desired by WHO for awareness of AMR. So let us all handle antimicrobials with care and ensure that implementable antimicrobial stewardship programs are being undertaken in our organizations and hospitals. Thank you. And I would like to answer any questions that you put in the chat box.
Thank you, ma'am, for such a comprehensive review of this vast topic and a very important topic. And one of the delegates, Dr. Yangshin, wants to know that culture facilities are not available in peripheral setups, though you are saying that IDSP is taking care of microbiological aspect, but how can we surpass this limitation?
Okay, thank you. Dr. Anuradha, can you hear?
Ma'am, there is some break in voice, but in between we were able to hear you. Yeah.
What?
Ma'am, question
What
is
I'll
that,
do is
ma'am, you can type it in the chat box, please. Yeah.
Box maybe.
Yes, yes, ma'am. Thank you, ma'am. Thank you, ma'am, for a wonderful talk.
Yes. Okay.
So I invite Professor Nusrat Shafiq, Professor in Clinical Pharmacology Unit, Department of Pharmacology, PGIMR, Chandigarh. And ma'am is convener of Antimicrobial Stewardship Committee, and she has been drafting several policies for the same, and she established models for post-prescription audits. She has initiated several activities within the ambit of antimicrobial stewardship, and She is principal investigator of Advanced Center of Clinical Pharmacology for Antimicrobial Stewardship. She has more than 150 papers in national and international journals of repute and is regularly bringing forth prescriptive of developing countries in the field of antimicrobial stewardship through various fora. I invite Nusrat ma'am. Thank you.
Good morning, ma'am. I hope my screen is visible to you.
Yes, ma'am, your screen is visible, but voice is breaking a little bit.
Oh, is it? Is it any better now, or is it?
Yes, ma'am. It has improved. Thank you.
Thank you. Just keep letting me know. I must thank you all for inviting me to the wonderful set of topics that you have arranged for today's workshop. Thank you very much, ma'am. And I would like to thank all the preceding the speakers for setting the stage for the talk that I'm going to deliver. But before I start, I would like to just say that what I'm going to talk about is one of the things, very small things in the entire framework of antimicrobial resistance. And this is something, this whole perspective is something that we really do not have to miss at any point, because there is one thing to, for understanding purposes, seeing antimicrobial stewardship as what I call it as salamization of making salamis of antimicrobial stewardship is good for understanding purposes, but for us to have very good impact on outcomes, we would need to see it in the larger framework of antimicrobial resistance. So having said this, I would like to start with the topic that has been assigned to me, that is prescription audit, framing a robust audit and its contribution to MSP. Now, robust audit is, something which is still a dream for us, despite carrying out this activity for the last 7 to 8 years. So just a minute, yeah. So I've already said, where does this talk stand? It's somewhere as a small, very, very small, minuscule speck in the entire galaxy of AMR. So we all have been reading about antimicrobial stewardship interventions. Some of them are well recognized to have some impact. Some others have not been shown to have any impact, but what is important is to understand is that most of this information comes from developed world, where healthcare infrastructure is framed totally differently. You will never see overcrowding in hospital setups. You will not see primary health facilities is struggling for some diagnostic workup or some access to important medicine. So, and they have these very efficient mechanisms for recording prescriptions, recording lab workups, interconnecting them. And it is easy to draw up the data, carry out various activities. So these are the things that they are not really grappling with, and we have to tailor our interventions around these realities. So we can't really apply the information that comes from them. So it has to be very, very rooted. All the interventions that we do have to be very, very rooted. So as Dr. Aarti had so beautifully described some of these interventions and their utility, I would just like to reiterate that guidelines are there, formulary restrictions have been described, education and training have been described, post-prescription audit and feedback. These are some of the interventions that I've listed here. They are ones which have shown some impact. And in our experience for the last few years, I think these are useful interventions. So I think as a group, we must focus on these interventions. So alone,
Bye-bye.
alone, any one of this would not work. It is only a group of these that will work. And when we talk about these interventions within the realm of antimicrobial stewardship, I think it is very important to understand that it is infection control interventions which are actually going to bring down the use of high-end antimicrobials, which are actually going to bring down the burden of multi-drug resistant pathogens within at least hospital frameworks. So basically, it is these collaterals that we have to go on addressing from time to time, and I think all the time. So I'll just want you to take a look at these two prescriptions there. One of them was communicated to me by one of the colleagues in internal medicine, and this was a patient referred from a corporate hospital within Chandigarh. The patient was already on imipenem, tigecycline, and polymyxin B. And there are some of them we could really do not make out whether they were antimicrobials, antifungals or not, because of the way they had been written. So I think, this is just to show one example. And the other one is from one of the outpatient settings in a local district hospital. Can you even make out what is written there? And now these are the realities we work with. So these are the extremes that we worked with, when it is actually a situation of variegated, extreme variegations that we have to deal with. And it is these extreme variegations that we have to keep tailoring our strategies around. So we will go on seeing what can be done in the realm of post-prescription audit and feedback. Most of what we do is post-prescription audit. Once the prescription has been written, then you do the audit and then you send your feedback. And basically, the pre-prescription audit would have things like formulary restrictions and formulary and guideline compliance and all those things. But it is the thing that we're going to talk about is the audit and feedback mechanisms that are brought into play after the prescription has been written. So over the period of time, we have been able to activate this process to a large extent within the hospital setup. But I would like to confess that even after so many years, it is not that every nook and corner of the hospital is covered. The reasons for that we can just touch upon, but and those would be the challenges for any kind of healthcare setup, be it a corporate setup, be it a government setup. But having said that, I'll tell you that wherever these audit and feedback systems that have been initiated within the hospital are working, they're doing a pretty good job. So what we did was, first we generated a form, and the form is like, the version that you're seeing is the 5th version, and the 6th version is already being developed by is already being piloted in one of the units. So what we did was we sat with different stakeholders, and that means we sat with consultants from internal medicine, intensive care unit, we sat with consultants from all the surgical specialties, and then we constructed this form. The important features here are what you see here is the demographic, some diagnostics that we have made a provision for provisional diagnosis, because we understood early on that diagnosis takes a long time to get established. Then we also have mention of previous antibiotics. That may not be such a consideration in other setups, but for our setup, it was very important consideration. Then this is the main body wherein we have information about antimicrobials as they come in and the purpose for which they're being given, empiric, prophylactic, or lab-based. So we ask the residents to point out whether it is given empirically or is it given prophylactically or is it lab-based, start and stop date, and then the reason for giving antibiotic. Of course, the details about dose, frequency, administration, all those things are also there. Then there is a separate section on antifungals. Right from the beginning, we were very cognizant of the fact that antifungal use deserves as much attention. So we do not have a separate antifungal stewardship program. We have it within the ambit of antimicrobial stewardship program. And a lot of information and a lot of intervention in the feedback is centered around this antifungal use as well. Though this is more of a problem in intensive care setups, it could be a problem in other areas in the hospital also. Then their diagnostic workup is also accommodated within the form. And what is important is the outcomes. So we say that at the end of a patient's follow-up in a particular unit, on the last date, what was the outcome? An outcome, again, we have divided it into several components. Now, in order to facilitate this outcome assessment, we are piloting another approach where we say that we have developed this acronym SWID, same, worsened, improved, and dead. So that kind of approach we are trying to incorporate. And whenever we say that we are trying to incorporate, we pilot it in one area and then we see what is the impact and then we run it. So it is a continuous process. The backside of the form, the current version also has details about such as, which helps us in making our decision about the clinical status of the patient. That information contains the details about the counts, the creatinine clearance, the oxygen requirement required for inotropic support. These details help in understanding whether there was actually a need for change of antimicrobials. So this is the first thing that we did. We got them incorporated in patients' files. At some places, the residents are filling it. At other places, our resident fills it up. By our resident, I mean clinical pharmacology residents. Not only residents, our PhD students, our MSc students, of course, for them it is voluntary. But our MD and DM, it is a part of their hospital service so that they have to provide. So they fill it up and they capture all the details. This itself took us a long time. It had to go through several rounds, through several committees, and finally it was incorporated in the files. So this is the first step that you can that one has to do. You can have your own form. I am aware of several different versions of such forms being used in other centers, and I think it is best to do it that way. Something can serve as a template, but it is best to use your own form. The first thing that the first year JR or somebody who is not so medically oriented is taught to do is to look at the doses. I mean, somebody who's just come, it would be difficult for them to grasp the nuances of rationale assessment. So we teach them that you have to see dose and administration, and some very interesting findings would emerge out of this. For example, the way amphotericin B was being used and was being declared as useless or something to do with the generic versions being available in the hospital supply. But when we looked, we understood that it was the administration of the drug which was totally at fault. The vehicle was something which was not even, it was recommended not to be used. So those kind of things they emerge. And I think it is very good idea, especially if your pharmacology department is involved, to make the JRs and SRs comment about dose in the first place. Then comes the choice of drug. This I will go in a little detail, and then duration. So one thing that can be easily done is that you say that it is perhaps too long it is being used. So we say if it is for profile access, anything beyond 1 day should be catching your attention. If it is an open fracture, as per the guidelines of the unit, should not go beyond 3 days. So we give these ready to eat, easy to consume kind of information to somebody who is not all that well trained, and we say that you audit these aspects. So the point is you have to tailor it also according to the workforce that you have. And so next comes the rational use. Appropriateness, describing appropriateness is very, very difficult, because the clinician always comes up with an argument for appropriateness. So you have to be as good as them in determining the appropriateness, and that doesn't happen over a day. And if left to the resident, it will not happen. The consultant has to be there, somebody who is himself or herself very well acquainted with the entire process of determining appropriateness and the evolution in it, has to be there on the ground for the initial training. One thing we have to understand, guidelines have a limited application in determining appropriateness in a hospital setup, because patient will seldom come with a diagnosis. They will come with some kind of a set of presentations, and you have to make your guesses about the possible foci of infection, the possible organisms involved. So these are not arbitrary guesses. There is a science in making these calculated guesses, and there is a lot of training. You have to train yourself. Okay, the presentation is like this, it is likely to fit into the picture of gram-positive infections or gram-negative infections, or multi-drug resistant pathogens, or even non-bacterial infection is a possibility. So that kind of understanding has to be built in. Then purpose of antibiotic. We understood, say 2 to 3 years ago, we started understanding that a prescribing doctor would or quite often mention it as a prophylactic drug. Then we understood they're perhaps not understanding the difference between prophylaxis and empiric, and that was the reason for a lot of issues that were occurring with the prescriptions. So what we started emphasizing upon was that make it have this understanding very clear. And during our bedside rounds, during our discussions, we started bringing this issue repeatedly, and now at least we can say that for the people who have gone through these training, this kind of understanding has become clear. So even for audit, it is very important to mention whether it was used empirically, it was prophylactically, or it was lab-based. Very often we tell you, say what the resident there is saying. When a person goes for audit, you note down what the resident who has written this prescription is saying and what you think. So then we are able to find out where the discrepancy is, because this kind of information helps us in giving the right kind of feedback. And then it comes the reason for change or de-escalation, escalation. It's a dynamic process. Patient profile is a very dynamic process. I mean, they would be fine today and they would be dipping next day. So in such a case, even escalation would be very appropriate. Not always it's the de-escalation which is appropriate. It is escalation also which is important. So that kind of understanding has to be developed in those who are going for audit, and it's quite a task. Then we started understanding the term sepsis was being used rampantly and indiscriminately. So a lot of our feedback started centering around these appropriate classification of sepsis and septic shock. Because it tells you it helps you in determining whether you have time to buy, can you wait for the culture reports to come or not. So that kind of things which are never mentioned in any of the guidelines have to be built in there. Then now we have started working on this aspect that the resident who goes for audit has to say whether it is HAI or CAI. So because that helps in making an estimate about the kind of organisms that would be there. That also helps you in determining what are the possible organisms and what are the possible antibiotics which may be used empirically. You see, lab-based is rather easy. It is the empiric treatment which is most tricky. Prophylaxis, most of the places now have guidelines. Some are in the process of making those guidelines. Even that is easy bit. Then availability and applicability of evidence. Now we have this whole issue about people using combination therapies in most settings, in certain settings. Where is the evidence? I mean, you have experimental evidence, but clinical, hardcore, robust clinical evidence is lacking. So your feedback also requires you to generate a lot of evidence. So at times we spend six months in generating an evidence for us to make a certain claim. And that was the thing we did for double anaerobic cover. We also generated evidence in a small group. We generated this evidence. Even the same strategy was for prophylaxis. In your CTVS, we used to have a cocktail of 3-4 antibiotics being given for 5 days till the drains were out. So the generous consultant, Dr. Sham, was there, and he said, okay, you try your approach on my patients, give me a 6 months evidence that there is no increase in infection, and then I'll have it rolled out as a policy. And that 6 months of hard work was done by our residents, and then it was shown to the group meeting. And fortunately, we see that till date, that is being practiced in a considerable number of patients, though universally, I would claim. So what we understood, we were working with the 4 other centers as part of our advanced center. What we understood that people had a big hesitancy in, say, determining appropriateness. And we realized that it is important that we bring everyone to the same level. So we as a group, people who work here within our institute, to try to develop a kind of pathway kind of thing for determining of what do you call it, as appropriateness of antimicrobials. We piloted and published it, and now we are trying to validate it. Hopefully we get good results with the validation aspect. We will be able to help other institutes in adopting the same approach, because this we understood was really tricky bit. In the end, I would say design local and practical pathways for management. And this has really helped us in 2 things. Acute febrile illnesses, which come to emergency, especially during the time when scrub would be there, typhoid is a possibility, malaria is a possibility, and even your dengue is a possibility. So, and your diagnostics, we understood what is the kind of turnaround time. When I say practical aspects, you have to keep in mind the turnaround time for diagnostics that will, that is to be very realistic. And with that approach, we developed a pathway for antimicrobial use. And believe me, the kind of difference it made was very remarkable. But that meant that every day our resident had to be there. Every Tuesday, I had to spend 3-4 hours there with their consultant during the round. So it's quite a lot of hard work, is another thing that I would like to emphasize upon. Similarly, we did for some of the infections, especially the antifungals used in during the second wave of COVID, and there we kind of made a pathway for streamlining the use of antifungals. So our policy is based on this understanding. It took us 6 months to frame this policy, and 6 months, and I would say around 6 to 7 rounds of sitting with each of the many groups that were involved in generating this policy. So here is just an example to show that our recently one of the anesthesia department, our anesthesia department, our trauma critical care unit had organized a training session on antimicrobial use. And this was an example that they picked out from their case. So you can go through this example wherein this was a real case. This is just to exemplify how this approach is carried out on a day-to-day basis. So the case was presented to us, and then the same approach was adopted. whether it was, we make a guess about possible organisms, you make a guess about the time duration you have for waiting for results, for making any changes, waiting for the reports for making any changes. You understand whether the patient is stable, the patient is afebrile, and you strategize accordingly and you make a pathway. And this is how the pathway would run. For this, I've taken a very simple situation to make it clear that every situation demands a different kind of pathway. And these pathways should run in the mind. Not every time you will have it as written. There are common principles, and then you start making it nuanced for specific situations. So this is how our advice went. So, and they incorporated it in their training sessions. So this, you would wonder, how is man jumping from something which was post-prescription audit and feedback to something which is looking very ghastly? This is just to show that, how fear is fueling most of the well-funded or well-yielding, economically yielding industrial enterprises. If you take the example of insurance, where it is a fear of you losing your health, you dying, nobody to take care of your family. You take the example of farm industry. The enemy is there. The other is going to eat up your land, eat up you, eat even and whatnot. And then maybe there's an attack from Mars. And then there is this very real fear of, you losing out on so many things for which you have to take legal aid. And then, of course, there's some fears that all of us are afraid of looking aged or having some blemishes on the face or something here, there, or a white streak of hair. And this is just to show that how fear can really change the scenario. But these are more of imaginary fears. Now I will take you to a different set of things. These are some of the real conversations which have emerged during several discussions with my clinical colleagues. And I feel now, after so many years, that to say stop is very easy for me. It is not so easy for them, because they work under these very, very real fears. When a consultant knows that there is a fear of contamination during the surgeries that they are undertaking with MDR bugs, I think that fear is real. So unless and until that fear is addressed in totality, we cannot be very brash about recommendations. So this understanding I've developed over a period of time. And this is the understanding that all of you who start audit and feedback will develop. Because it's very easy to tell somebody else to do this and that, but when somebody is responsible there, it's a different situation, and we must accept it. So I'll give you this example of a pregnant lady who was getting her routine first trimester workup. She was told repeated urinary examination revealed E. coli, which was MDR bug. Patient was ambulatory, doing very fine, doing duties. She was advised imipenem, so much so that the consultant said, if you don't get admitted, I will force you to get admitted. Of course, it was a motherly kind of love she had for the junior consultant who had gone to her, and she had a very genuine reason, because she was aware that UTI is an important cause of pregnancy loss, and she knew that the pregnancy meant a lot to the junior consultant. But the junior consultant was a little stubborn. She went and she said, just give me one more chance. I'm ambulatory, I'm afebrile, I'm totally asymptomatic. Let me get the workup done very thoroughly. The sample was sent with due care, and processing was done with due care. And what you got was, there was no bacteriuria there. So basically, this was just to highlight how fear is important. How do we, now we come to, so having said all this, I would say, how do we give feedback? So much to also about audit. Feedback can go in different forms. Tailor it to the convenience of your own convenience and the convenience of the treating team. So we use the paper format, we use a WhatsApp format, and now one of my senior residents has Dr. Samiksha Bhattacharya has come up with a very novel format, which she has implemented also in one of the units within the hospital. She has developed this 2-page format. She puts it in the files of the patients and she writes the recommendations at the end. So below this table, she writes a recommendation from time to time. Stop clindamycin, stop, suggested to stop clindamycin. We never say stop, we suggest. Yeah, so I think, is it, ma'am, time is, how much time do I have with me?
Ma'am, your talk has been so interesting. You have overshot 10 minutes. So can you please wind it up in 2 minutes, please?
Yeah. So I will do that. Sorry about that. So outpatient settings remain a challenge because there you really do not have any method to care, and it's so widespread. So I think the best way to go about doing this is to have your guidelines and see just the compliance to guidelines. Who does all this work is important to understand. We really do not have dedicated manpower. It is the residents who do this work under my guidance. Now, luckily, I have 2 other consultants who help me out on this work, but one has to devise a strategy around the available resources. Very important is to train the personnel. You have to understand what is the knowledge level they have got. If it is a medical who is trained in rational use of antimicrobials, who is trained in evidence-based medicine, like our pharmacology residents, then it's very useful. Otherwise, if it is somebody who is a nursing staff, you could still do some part of your work by making them understand this is the prophylactic guideline, note the deviations. So you have to train your personnel as per their available skill sets, and what you plan to do has to be tailored according to them. Why do it has been very elaborately and beautifully told by Dr. Aarti, so I will not go into it. And some of these improved outcomes we have been able to show. So it's very important to measure. So what do you measure? You measure defined daily dose, you measure days of therapy, you measure length of therapy. But the thing which is most important is use of designated or reserve antimicrobials, de-escalations, and appropriate antimicrobials. Of course, you have to use appropriate denominators. C. difficile, I've noted, is not such an important outcome in our setups. So I don't know how it works out for other setups. Some of the low-hanging fruits for this audit and feedback could be surgical prophylaxis, double anaerobic cover, or for that matter, any redundant use. You could target redundant antimicrobial use, 2 antimicrobials to kill Pseudomonas, for example. Dose and administration is another very easily doable thing, and more than 3 antimicrobials at a given time. That could also be a very important low-hanging fruit. There are challenges, which are a lot of them. You need somebody who is ready to devote 3 to 4 hours of every day on this kind of activity. So that's quite a lot of hours, considering the number of activities each one of us is doing on a day-to-day basis. So I think I would like to conclude by just saying that you have to devise it according to the setting, according to the resources. For example, in district hospitals, you do not have such a variety of people to have antimicrobial stewardship committee. So you have to come up with a different kind of strategy there. So I would like to sum up by saying that you have to adopt a tailored approach. Experience sharing can be immensely important, and audit and feedback alone will not help. It is the collaterals which are going to make the real impact. And the most important collaterals for our setup have turned out to be overcrowding and infection control. So I think with this, I would like to thank you and would be happy to take any questions. Thank you.
Thank you, ma'am. What an enlightening session. Wonderful. We didn't want you to stop, but because of time restraint, some other time again, we will have a more elaborate session on this. Please use chat box for the queries from the ma'am. That is my request from the audience. Thank you, ma'am, once again. It was wonderful to hear you.
Thank you, ma'am, and my apologies for overshooting. I just lost track of
No.
Yes.
No, it was all our pleasure. We will cut short the tea break then. Thank you. Thank you once again.
Thank you.
Now I take pleasure to invite Professor Pallab Ray, sir, who have been involved in the CME from the inception. It has been his planning and his guidance. So we are here today. So he doesn't need any introduction. As we know, he's the current president of Indian Association of Medical Microbiologists. And he has been working as the principal investigator for ICMR Nodal Center for AMR in anthropocracy and has conducted various workshops and CMEs on antimicrobial resistance. And he has been actively involved in AMSP of BJMER and expert in framing national guidelines. He has more than 150 publications to his credit and has guided more than 20 MD and 30 PhD students. So I invite our Pallab Ray sir for the talk on how to use antibiograms. Okay.
Recording stopped. Recording in progress.
Good morning, ladies and gentlemen. Today we are going to talk about making sense of cumulative antibiogram. Let us first look at it. Why do we need cumulative antibiogram? That is because it helps clinicians select empirical antibiotic therapy, the epidemiologist to track trends in AMR over time locally, and it helps in surveillance for emergence of drug-resistant bugs. A cumulative antibiogram supports clinical decision-making, local antibiotic protocol revisions, formulary decisions, infection control interventions, and AMR containment strategies. And another important thing is this is one of the essential functions of a clinical microbiology lab. So it's very, very important, but most of us are in the habit of keeping a record of all our antibiotic resistance data of our isolates in Excel sheets with whatever data is available. This is what we call is the line listing. When the line listing is finally analyzed and the results of the susceptibility of organisms to various drugs, it's presented in an analytical form, either in the form of a table or in the form of a graph. We call it an analyzed version, and that is exactly what we call cumulative antibiogram. Now, what is the definition of a cumulative antibiogram? The definition is very complex. It's a report generated by analysis of results on isolates from a particular institution in a defined period that reflects percentage of first isolates per patient of a given species susceptible to each antimicrobial agent routinely tested. Very complex definition. Let us tear it apart and see what are the components. We have said it's the report generated by analysis of results on isolates from a particular institution. So it has a defined institution. It belongs to an institution in a defined period. So you have to also mention what is the defined period that reflects percentage. So it's always presented in the form of a percentage of first isolates per patient. We'll come to details about it later on, of a given species. So the organism has to be identified to species level. You cannot present an antibiogram of a genus or a family. So it belongs to a given species, susceptible to, never present the data in the form of resistance, always present the data in the form of susceptibility to each antimicrobial agent routinely tested. Do not include any antimicrobial agent which is not routinely tested. A cumulative antibiogram suffers from some problems. One problem is poor comparability of antimicrobial susceptibility statistics between institutions because of various reasons. Number one, a non-uniform inclusion criteria. Which specimens, which isolates, which antibiotics to be tested, they differ from institution to institution, and this leads to a bias. Then a simplistic calculation approach and diversity of calculation methods by the labs. And third is a strong tendency to overestimate drug-resistant rates. And that is the reason why we always say that you must present it, this is the rule, the susceptibility and not drug resistance. What is the relevance? It's essential to have uniform policies and rules for data collection, compilation, and presentation and analysis, because that allows us, that ensures comparability and allows us to merge the data between and with other institutes at regional, country, global level. Now, how do we actually export the data? Let me give you a couple of examples. Suppose we have more than one isolates from one specimen. It should be unambiguously reflected. Two isolates from blood culture should reflect full information. The same date, 14/1/19, the same specimen number. We have isolate number 1, Staph aureus. Isolate number 2, same date, same specimen number, the same specimen, Staphylococcus epidermidis. So both of them should be reflected properly. Sometimes we carry out multiple test panels. The test panel 1 is tested on day 1 and panel 2 on day 2. And in this case, sometimes the same organism, same isolate gets repeated as a separate entry on the next day, and this creates problem of an antibiogram. Now, one must import all verified and finalized antimicrobial susceptibility test results with required data and analyze the data for a defined period to generate line listings and cumulative statistics and remove or edit incorrect data. For example, I report an isolate today, and after that the clinician rings me up and tells me that the patient is all right. Then you decide that then probably the isolate is a contaminant from the skin. And if that is the case, then remove it from the record. It should not figure in the cumulative antibiogram. Now, there are certain patient demographics which are absolutely required and some of them are desirable. The unique identification central registration number and the facility, if the lab is serving multiple facilities like multiple hospitals, it should be definitely required. Desirable is date of birth or age, sex, location when sampled, the clinical service, the admission date. The admission date is not absolutely essential, but if it is there, then you can later on analyze it on the basis of whether it can be defined as a hospital-acquired infection or a community-acquired infection. Required is specimen number, specimen type, date and time of sampling. Desirable is body site. Required is identification to species level. It must be identified to species level. Desirable is isolate number if we have multiple isolates. And there should be a mechanism to keep taxonomic continuity. For example, an organism which was 30 years ago, it called Pseudomonas maltophilia, about 20 years back became Xanthomonas maltophilia, and now we know it as Stenotrophomonas maltophilia. So there should be a mechanism to keep taxonomic continuity. You must differentiate between colonization or infection. We do not want to include colonization organisms into a cumulative antibiogram, and whether it's community or hospital acquired. It must reflect quantitative measurements, MIC and or zone diameters, and categorical interpretation, sensitive, intermediate, sensitive, dose dependent, resistant. Expert rules in automated systems, if it is indicated, it should be reflected there. All relevant agents tested, it should be there. The method used, and if there is a specialized test result, then that should also be included as a separate field in the cumulative antibiogram. Well, how frequently should one carry out the analysis of a cumulative antibiogram? At least yearly. More frequent analysis if you have large number of isolates, newer antimicrobials are introduced and you want the clinician to know about its behavior to the antibiotics. And if there are clinically important changes perceived, suddenly you believe that the resistance to carbapenems or to polymyxins have suddenly increased. You must rule out an outbreak in that situation. But if it is more frequent than yearly, there are problems because seasonal variations may affect the antibiogram. And smaller numbers, if you have the number, CLSI always says do not include a species if the number is less than 30. Because when the number is less than 30, the confidence interval statistically becomes much, much wider. I'll give you an example. Suppose this is a table for statistical analysis. On this side, we have sample size. On this side, we have susceptibility, how much susceptibility is. So if we have, say, Klebsiella pneumoniae, 30 isolate is the sample size, and 50% is the susceptibility to an antibiotic, or maybe the sample size, if it is 10, and 50% is the susceptibility, then the confidence interval is between 19 to 81. That means a 62% variation between in the range of the confidence interval. Similarly, if the sample size keeps on increasing, the confidence interval keeps on decreasing or narrowing down. So I'll give you a better representation of the same data. If the sample size of an organism keeps increasing 10, 20, 30, 40, 50, 60, 70, and if the percentage sensitivity is 50%, then this is the confidence interval. So at 10 sample size, 31 on either side. At 20, 23 on either side of 50%. At 30, it's 19 on either side. See, the number is decreasing. I have represented the same here. If you look at it, from 10 to 20, an increase in number, there is a reasonable narrowing down of the confidence interval that means build up of confidence. Even 20 to 30, there is again a substantial reduction, but after 30, the reduction is rather more modest. And that is the reason CLSI has taken 30 as the minimum number for calculating percentage susceptibility in a cumulative antibiogram. Only first isolate of a species per patient per analysis period, let us take it as 1 year, irrespective of body site, susceptibility profile, phenotypic characteristics, or how many events of disease the patient has. So only the first isolate should be included in a cumulative antibiogram. There should be a provision in the database to store all isolates tested, but then filter out only the first isolate in case of multiple isolates of the same species from the same patient in that particular period. Only isolates more than 30 should be reported, 30 or more than 30. Only clinically significant isolates should be reported. If it is insignificant, don't include it in a cumulative antibiogram. Antimicrobial agents selection should be only those routinely tested and appropriate for that species should be included. For surrogate testing, do not mention the surrogate agent. Report the agent represented. You may test cefoxitin for oxacillin susceptibility for Staph aureus. Do not mention cefoxitin in your cumulative antibiogram. Mention oxacillin. Selective reporting. Remember, cascade reporting is the rule of antimicrobial stewardship, but cascade testing is unacceptable. Many people, what they do is they test for a limited number of antibiotics on day 1. And if the isolate is resistant to the first line, then they test for the second line. In that case, look at the bias for the second line of antibiotics. They are tested only for the isolates which are resistant to the first line. So it will be biased in favor of more resistance because all isolates, particularly the isolates susceptible to the first line, have not been tested for the second line. Supplemental drug testing should not be included. Calculations report only percent susceptible, not resistant. Do not include percent intermediate. For virulent streptococci, percent sensitive and percent intermediate separately for penicillin is recommended. Always use current breakpoints. Be careful about comparison with previous data using previous breakpoints. MIC should be recorded to 2 decimals only, not more than 2 decimals. Dilutions other than 2-fold to be raised to higher CLSI 2-fold equivalent. For example, you must have seen in the e-test strip, you have 2 microgram per ml, you have 4 microgram, and in between you have 3 microgram per ml. The value 3 doesn't fall into the 2-fold dilutions. Do not include 3 in your cumulative antibiogram. If it is 3, then you raise it to the next 2-fold equivalent. Off-scale MIC values as uninterpretable if breakpoints are revised. Sometimes in many of the drugs with automated systems, you will get MIC more than 4 microgram resistant. Now, these values cannot be represented, cannot be calculated later on, and therefore they are actually uninterpretable, but in any case, they can be mentioned in that form, but they become uninterpretable if breakpoints are revised later on, and the breakpoint goes to the range of more than equal to 4 microgram per ml. Only if you have less than 30 isolates of a species, we have already said, do not give the percentage. Try to question yourself, is it essential to include that species? If included, put note that less statistical validity. Susceptible in vitro but clinically inappropriate should not be included. For example, aminoglycosides for Salmonella typhi, they may be sensitive in vitro, but they cannot be used in a patient because they don't work on intracellular Salmonella typhi. If only sensitive category is described by CLSI, percentage sensitive should be 100%. If you get an isolate which appears to be resistant, investigate or report it as non-susceptible, but do not include it as resistant, because resistant category doesn't exist with CLSI for that drug bug combination. Percent sensitive for combinations of antibiotics can be calculated later on, though it's not an essential part of cumulative antibiogram, because it helps the clinician in formulating their empirical combination therapeutic policy. So you can carry out A and or B susceptible, which combination can work, or like that type of calculations can be done later on. Table or graph with data accumulated over several years may be presented for trends for certain specific situations. For example, Staph aureus percent susceptible for oxacillin, Enterococcus species percent susceptible to vancomycin, E. coli to cotrimoxazole in urine and fluoroquinolone in urine, Klebsiella pneumoniae, E. coli, ESBL positive, Pseudomonas to carbapenems, say carbapenem resistant Enterobacteriaceae, Pseudomonas aeruginosa, and Acinetobacter baumannii, or colistin sensitive or resistant gram-negative bacteria. The trend can be shown. If you go to the CDDP website, you will see that they show each organism for each antibiotic, the trend of resistance. They don't show susceptibility, which should be the norm for CLSI, but they show resistance over years. The same can be done, but there is a caveat here. The question is, an organism which shows, say, 80% susceptibility today or last year, this year the susceptibility has gone down. Now, how much going down is to be taken as statistically significant? So there are tables available for that. This is one of those tables for reduced susceptibility. Suppose we have sample size of 100, say 100 Klebsiella pneumoniae, with a susceptibility last year of 80%. Unless it is 66 or below 66 this year, do not say that susceptibility has gone down. Similarly, I'll show another table for increased susceptibility. The same example, 100 Klebsiella pneumoniae, last year's susceptibility was 80%. Unless it goes beyond 91, do not say that susceptibility has gone up. Okay, so there are certain limitations of cumulative antibiograms. They do not consider patient factors, past history of infection, antimicrobial use. So therefore, not useful for guiding treatment in recurrent or relapsing infections. It's not generalizable to all patient populations. Say, for example, a cumulative antibiogram of a hospital doesn't stratify the results into immunocompromised or HIV positive patients and the immunocompetent patients. Not generalizable to different facilities. A hospital antibiogram may not be generalizable to the community. not useful for monitoring the emergence of antibiotic resistance during treatment, because we are not taking multiple isolates of the same individual belonging to the same species. We are taking only the first isolate. And it's not useful for identifying trends of cross resistance to other drugs. For example, out of, say, I pose a question, out of all E. coli isolated from urine, how many of them they are susceptible to nitrofurantoin? That kind of an analysis, a cumulative antibiogram doesn't allow us to do. So that can be done only from line listing. Therefore, the line listings are extremely important. Antibiograms, they help antimicrobial stewardship programs to select antibiotic, develop guidelines, identify susceptibility trends, and line listing helps in another thing for individual patients. Sometimes the phenotypes or phenotypic resistance to a particular set of antibiotics may point to genotypic mechanism of resistance, which can be extrapolated to drugs. Multiple resistance determinants sometimes blur the predictability, but if a limited number of drugs show resistance for an isolate, it can indicate a particular genetic mechanism of resistance. So that's all I had to say about cumulative antibiogram. Thank you very much for your kind attention. I am available for any questions if you have any. Thank you very much once again.
Thank you, sir, for such a beautiful talk. And I'm sure we all have gained so much and we will utilize it at our own hospitals. And I would request delegates to put their queries in the chat box. Thank you.
With this, we conclude the session 1. Now, in the scientific program, we have a tea break here. But since we are running out of time, I now start the session 2. That is one liberty we can take in online CMEs. So for the session 2, the first talk that we have is entitled Stewardship Starts with the Right Diagnostics. I invite Professor Anuradha Sharma, Professor in HOD Department of Microbiology at Aiims Bilaspur, for her talk. Please, ma'am.
Very good morning. So I am presenting on stewardship starts with the right diagnostics, and these are my disclaimers, these are my references, and you have already seen that Dr. Aarti Kapil ma'am showed this slide to you earlier. This is from the Messecker et al. And we see that the diagnostic stewardship starts right at the moment a physician decides to ask for an investigation. So right choice of test is the most important at this end. And for a microbiology laboratory, it is turnaround time. And for antimicrobial stewardship, if we can restrict any empirical therapy only for 24 hours, so it finishes off with all the stewardship which we are covering today. So in this one slide, the message goes that the right choice of test, the right turnaround time for the lab, and if we can restrict our empirical therapy for less than 24 hours. So we all are aware about the various viral infections prevalent and pandemic right now, and everybody knows how to go about for viral diagnosis and what are the availability in our own country, so I'm not touching it. And I will be talking only about the low-hanging fruits which we can add in our apple cart and don't topple it. So the first slide is point of care and point of can. So as in earlier talks, they have mentioned that what is happening at community level? That is the concern for everyone. So with the advances in our technologies, combining automated readers and interfacing with distant laboratory information systems, now it's the responsibility of reference laboratories to provide the diagnostic at community level, at PSCs, at CSC level. That is the next target for the governments all across the globe. So from that article only, I cover up the most important, most crucial aspect, that is febrile illnesses in low resource settings. So they are basically life-threatening conditions and they all require specific therapy. So here, if we can use the laboratory services of microbiology in the best possible manner and save our antibiotics from being used for empirical therapy beyond 24 hours, that would be the best. So with the malaria well in control in last 15 years in majority of the countries, invasive bacterial infections, especially MDROs, have become the most important challenge, and even at community level, even in the peripheral setup. So I believe I'll take this topic first. So sepsis needs blood culture, and the clock starts ticking from the moment a physician decides to go for a blood culture for the patient. Remember this as a microbiologist, that the clock is ticking for the patient the moment blood culture is decided. So there is an increase in mortality 7% per every hour. We all know there are three stages of analysis of a laboratory report: pre-analytical, analytical, and post-analytical. And up to 70% errors occurs in pre-analytical stage. So these are the areas, that is incorrect analysis order, patient preparation error, sample collection error, transport error in pre-analytical stage. This is happening before the sample is received in the lab. So all physicians must know these and they must take care of them to get best results from the lab. Otherwise, whole exercise is a waste. So at analytical stage, of course, microbiologists must know what is the contaminant, what is the commensal, and how to reduce the turnaround time. We'll be talking about this, and the correct interpretation. So aseptic collection of blood for blood culture is most important, and we must even clean the decontaminate the bottle tops, and we must collect 20 ml of blood and inoculate two blood culture bottles, one aerobic, another anaerobic, and incubate the media as soon as possible. So the most important factor which influences a blood culture report is the volume of the blood. Remember, in adults, there is less than one coliforming unit per ml of blood. That is, less than one bacteria is present in an adult. And whereas in pediatric patients, it is usually up to 100 bacteria per ml of blood. Therefore, in pediatric patients, even 1 ml of blood for culture will give you a positive report, whereas in adults, especially in enteric, this implies that there's less than one bacteria per ml of blood. So now see, if you are collecting 20 ml of blood, still you are missing 30% of the patients of enteric fever, though blood culture is the gold standard for enteric fever. So adequate amount of blood collection for blood culture is the foremost requisite, and two blood culture bottles, one aerobic, one anaerobic, should be inoculated. So remember, most of the pathogens in our country are facultative anaerobes, so we don't want to miss them, and it is happening so that in our country mostly aerobic blood culture bottle is being used, and they are strict aerobe level, they are very important. So we must use two blood culture bottles, one aerobic, one anaerobic, and order of draw that always, whether it's a conventional blood culture or an automated system, first tube to be inoculated is of the blood culture. So So this is a flow of processing of blood culture. It has been picked from UK sepsis guidelines 2Kit 8. So here is the patient, and according to sepsis guidelines, within 1 hour of admission of the patient, the samples should be, the patient should receive the antibiotic, okay, to reduce the mortality in sepsis cases. And always remember to collect blood culture samples before you start the antibiotic. So within 1 hour of admission of a suspected sepsis or invasive bacterial infection, the sample should be collected and patient should receive the antibiotic after that. So then comes transportation. Now this is very important. In our country, hardly at few reference centers or in corporate hospitals, 24/7 microbiology services are available. So if blood culture is collected in emergency hours after the routine hours of the hospital, those blood culture bottles keep lying in the wards. Now, what happens with the non-fermenters, that is Pseudomonas and Acinetobacter, and also some yeast, the growth goes on in the bottle, and when it is uploaded in the system, these bottles are uploaded in the system, it is a continuously monitoring system, and it records the log phase of the growth, and that change in the pH or CO2 production is recognized by the system, and then it gives the flag, positive flag. So because growth has already occurred before, and probably those organisms have reached into lag phase or decline phase. So if the bottle will not give positive, it will not, the system will not flag positive, and you will miss the diagnosis. So please don't keep bottles after inoculation in the ward, and this time duration should not be more than 4 hours. So you get a big time that from the sample collection and inoculation in the blood culture bottles to transport and uploading in the continuously monitored automated blood culture system, time should not be more than 4 hours. Okay, and everybody should be aware of this. Now, after that, the incubation period starts, which we cannot, of course, affect right now, but there are advances and people are going for DNA fish, for PCR, for multiplex PCR microarray system, but we don't have all this. So we don't have to think about it. And they say, even if you have a molecular assay, and if you are not taking care of sample collection, transportation, then that cost is a waste. And all these resources are to optimize our results, not increase the financial burden on the system. So if we are taking care of these parameters in itself, it will help us. So after incubation, the moment it flags positive, we are supposed to do gram staining, and always gram staining needs an expertise. Okay, and it should be reported within 2 hours to the physician telephonically. Okay, don't leave it, or leave a message, WhatsApp message, or in whichever possible manner earliest you can convey the gram staining. Okay, and it should be done by an expert. Simultaneously, now in 2021, CLS says that the direct sensitivity testing from the blood culture broth should be put up, so that we have an idea by 24 hours what are the drugs which are effective in this patient. So the idea is to limit our broad spectrum antimicrobial therapy only to 24 hours. So the moment it flags positive, we are doing one subculture, other is we are doing a DST from the blood culture broth. And now there are guidelines for the breakpoint values at the incubation period of 8 to 10 hours. So after 8 to 10 hours, you can read the inhibition zone and you can convey it to the physician. So it all takes, if we look at it, it will be taking almost 18 to 24 hours. So within 24 hours, with your best intentions and 24/7 services, you can provide an idea, a preliminary report to the physician. Next comes at 36 hours. If all cultures are sterile, that should be your primary report of the blood culture, which should be automatically through LIS should go to the clinician that blood culture is sterile. So if a patient is stable, especially in neonates, if they are stable, they don't need the antibiotic, they can stop the antibiotic. Okay, so sterile at 36 hours should be convenient. Then, of course, we can do ID AST with multi-doc. Again, ID can be given within 24 hours. AST with automated system can be given within 24 hours. So that is the goal for stewardship, diagnostic stewardship in blood culture, and it is a very important life-threatening situation. So we can utilize it in this way with best intention. But can you see this conventional workflow, which take 48 to 168 hours, and how it gets worsened? Why there is such a large spectrum? Because if we receive a blood culture on a weekend, say on a Friday, and after 24 hours it should be subculture. So the subculture occurs on Monday. We have lost 3 days. Whereas if we want, we can examine the blood culture broth next morning within 12 to 18 hours. And if there is a turbidity, do a gram stain, report it, put a DST, and put a subculture, and go ahead. So you can reduce those 48 hours here, even by conventional workflow. Okay. So this is another diagram which the pink arrows show areas which we can influence, and we must have a 24/7 microbiology laboratory service. Now this is the data from Germany ICUs of 10 years period, which shows that how for each species of bacteria, the MDR organelles increases the mortality almost by 10%, which for Pseudomonas and Acinetobacter almost doubles. Okay, so from 15% it has become 50 here. So it's so important to report MDROs as soon as possible. Now this is a landmark study which shows that a delay in start of antifungal treatment by 48 hours increases the mortality up to 40%. So it's so important, and for certain ICUs in our country, this is the leading isolate. So it's so crucial to report it as soon as possible. Now AST, a long list of antimicrobials given in our AST report is not helpful. It should be a selective reporting. Okay, so it should be first line drugs, and the narrow spectrum should be reported. And of course, we must report only the drugs which are effective in that organelle. They are inherently resistant mechanism in bacteria, and we must take care of that. So this is one example, the MIC from a blood culture report where Klebsiella pneumoniae has grown. And this is the susceptibility breakpoint. And these black boxes show the MIC for this isolate. So if we have to decide the drug in this scenario, so the furthest away MIC will be the drug of choice, and that's how they have given in the comment that gentamicin is a drug of choice. But gentamicin is not given in this scenario all alone. Okay, so this is one concept, but other than this, there are other rules which we need to follow. Rule number 1: beta-lactam antibiotics give the best outcome in severe infection, so they should be our first choice, except in atypical infection. Rule number 2: do not compare MICs between drugs. They have different pharmacokinetics and different pharmacodynamics. They will have different serum concentration, different tissue penetrations. So if you have MIC which is equal to or less than, so can you use the drug? But there are exceptions. That is, either is the drug reaching the site of action? So in a case of UTI, you cannot report tigecycline. Okay, it will not be excreted there. Similarly, pharmacodynamically, gentamicin cannot be given in cases of abscesses. Okay, and if the drug is producing inducible resistance, yes, in spice organelles, we cannot report third generation cephalosporin. Then patient specific factors, the renal function, the liver function, the obesity, okay, blood loss, all that matters. And of course, drug cost. The fourth rule is that microbiology always has more information, as we said, that it is a selective reporting or a cascade reporting, as Sir said. So if you want to ask them or you want their help for additional tests, you can reach them. Now, here's one example. There's a blood culture with Enterococcus fecalis, and these are the MIC. All 4 drugs, ampicillin, dapto, penicillin, vanco, they are sensitive. And the smallest, which people go for after S, they will go for the digit of MIC. So smallest is 1. So do you think daptomycin is the best drug? No. Here, for the enterococci, the drug of choice is ampicillin, and it will remain ampicillin. Daptomycin is not better than ampicillin because the MIC is lower. You must understand that. And can we still improve it? Yes, ampicillin is superior than vanco or dapto in this order because of its cost. Okay, so microbiology always has more information. They must have done a testing for linezolid also, which is an oral drug, but we will not go for it because it is a bacterium with enterococci. So ampicillin will remain the drug of choice, that too through IV. Okay, so that is how we have to decide about the drug despite its sensitivity and MIC and the therapeutic index. Okay, so assessment question 2 is there is a urine culture, and Capsula oxytoca, which is TSBL producer, has been isolated. Now it is sensitive to cefotetin, levofloxacin, meropenem, nitrofurantoin, and tigecycline. So what drug should be used? Now we need to know whether it's a cystitis or pyelonephritis, because we must know that nitrofurantoin and fosfomycin, which are used for cystitis, they don't work on pyelonephritis. They can be given orally. Okay, so we must know whether it's a cystitis or pyelonephritis, whether it's a male patient or female, how old is the patient. So here is the cystitis in a young adult female with no comorbid condition. So do you want to give IV? No, we will prefer a oral drug here. So cefotetin and meropenem are the only sensitive beta lactams here. Okay, and we cannot compare MICs here because they have different PKPDs. So cefotetin should not be used because it is an ESBL producing organism, and the drug is given by IV route only. Then meropenem is again only IV route. Ciprofloxacin is resistant, so levofloxacin should not be used. And tigecycline has poor urine penetration and again is IV. So what is the drug of choice? It is nitrofurantoin. Okay, even if fosfomycin is sensitive here, which has not been reported by microbiology because of cascade reporting, it should not be used because it is more expensive. So nitrofurantoin will be your drug of choice. So that is how you should analyze and interpret the AST report. Another is that pathogen-directed AMSP can be done where your residents can visit the wards and see whether after the reporting of AST, escalation or de-escalation of therapy has been done or not, it has been achieved or not. That's very important. Most of the times it's seen that our reports are so delayed that physicians, they are not bothered to even look at the report. And if patient by then is stable because of so many antibiotics given to the patient, they are not bothered again. But remember, in those scenarios, de-escalation is very important. Then early and accurate diagnosis, but not overdiagnosis. We must not report commensals and contaminants. And remember, swabs are the most misused tests in microbiology. So for group A streptococci, group B streptococci, for diagnosing diphtheria and vulvovaginal candidiasis, only these are the areas. At other places, clean the wound because it will be teeming with the commensal flora of the skin. Clean and send a punch biopsy if you really want to do a culture from a wound swab. Use WhoNet, it provides wonderful line listing. It shows you clustering of cases, it shows you outbreak, and then there is this Sanford app is there. If you enter the MIC into this, and it will give you the drug of choice to be used. Then, very important area, diagnosis of enteric fever. Here, the Vidal test, which is rampantly written by physicians all across our country, is a redundant test. Why? Because the antibodies develop after 7 to 10 days of infection. And do you think any patient in today's era with high-grade fever will wait for 7 to 10 days for taking antibiotic? And consumption of antibiotic influences the result of Vidal test. The antibody titer doesn't rise. So you will miss the diagnosis. So best and gold standard is blood culture. Collect adequate volume of blood, ideally 20 ml minimum. and before instituting the antibiotics. Okay, so I request don't promote Vidal test at all. Then these are the challenges with other important febrile illnesses. If your ideal sample for peripheral smear is a capillary blood, if it is an anticoagulated blood, the smear should be made within 1 hour of collection of blood. 1 hour of collection of blood. In our country, the sample doesn't reach even in that much period. Okay. Then second is for capillary blood, the if first sample is negative for peripheral smear, another sample should be collected after 6 hours and another after 12 hours. So to detect the parasite, and ideally in reference lab, both the tests should be combined, that is peripheral smear and RDT, because RDT though is very good, it's a very good test for the peripheral areas, but it has sensitivity of only 85%. It will miss the 15% of the patients. Okay, so use both in combination and optimally. Dengue, the rapid test doesn't, it's not, it gives a probable diagnosis and doesn't detect reinfections. MAC ELISA is the recommended test by Government of India, but there's a lot of cross-reactivity with other viruses. So you must know about what test to use at what stage and what will be the issues, what will be the challenges with the results you get. Okay, scrub typhus, then brucellosis, very important test area in our country. It's a cattle rearing population, and if you get a history of recurrent typhoid-like illness, should think about brucellosis. Then leptospirosis, altered LFT, RFT, think about it. We have rapid antigen and antibody tests for Leishmania. So now the take-home message is early and accurate evidence, accurate, early turnaround time. Interpret it and communicate it. Don't sit on the report and see whether a physician has seen it or taken action on it. So now our clinical microbiologists have a new avatar. It's not only Sherlock Holmes detecting the pathogen, they are a warrior also, okay, to save our antibiotics. Remember, code blue is on. Thank you so much.
Thank you, ma'am, for the lovely insight into the antibiotic stewardship, the diagnostic aspect of it. I hope these golden rules will help us all in choosing the right drug for the right bug. Moving on to our next talk, I would like to invite Professor Shiv Prakash Rudramurthy, who will talk on antifungal stewardship. Now, Sir is currently working as section in charge of Mycology Division at the Department of Medical Microbiology, PGI Chandigarh. He has been a principal investigator for the study on invasive mold infections in ICU, as well as the management of mucormycosis. And he's co-investigator in the ICMR's Nodal Center for Surveillance of AMR in fungal infections. The research include several papers on antifungal research, endemic mycosis, rapid fungal diagnostics, and molecular mycology. He has more than 400 papers to his credit and has been a guide to more than 10 MD students and several of PhD students. Over to you, sir.
So there are some queries regarding precision dosing. Okay, then there are queries like
Over to you, Shiva sir, please.
Good morning. Mega, is it started?
Yes, sir, you're online, sir, please.
Yeah, I need to start now. Mega?
Yes, sir. Yes, sir.
Okay, introduction ho gaya. Just we went for a cake at Sarka. So just I was not aware. Sorry. So I'll just share my slide.
Yes, sir. No problem, sir.
Okay, thank you. Good morning to you all. Abhi sun rahe hai na? Mega, is it okay? Fine?
Yes, sir.
Okay.
Perfectly audible.
Okay, good morning to you all. First of all, I would like to thank Dr. Anuradha and her team for inviting me for this wonderful CME. So I've been asked to talk on the diagnostic-driven approach to the antifungal management. So first, coming to invasive fungal disease, you all know that it is a major cause of morbidity and mortality, especially in those with the immunosuppressed patients, because of many advancement, as it has been well known to all, such as solid organ transplants, bone marrow or stem transplantation, or oncologic malignancy, and even use of steroids in case of chronic inflammatory diseases. Increase has been also been noted in case of an non-neutropenic patient, critically ill, especially those who are in a different ICU patients. Even though it is an life-threatening, these fungal infections, prevention, diagnosis, and management strategies still remains as a moving target. So because the symptoms are frequently non-specific, and early diagnosis of invasive fungal disease is becoming very difficult to establish. So because of that, there is more and more use of empirical antifungals, which has been associated with an toxicity. And also because of use of this increased use of in empirical, we are getting this drug resistant organisms. If I want to tell on one slide of the burden of the fungal infection, especially in this this one, hematological malignancy or immunosuppressed, this is a single center study. It is a landmark study to tell you what is the burden of fungal infection in those immunosuppressed conditions. So the autopsy studies, large number of autopsies have been done. You can see that 30% of the patient who died of hematologic malignancy had invasive fungal infection. So of that, 75% were not diagnosed before the death. So major organisms. So diagnosis of fungal infection is really very, very important. That too, early diagnosis is really very, very important. So you also know that there is a changing in epidemiology. Changing in epidemiology is occurring now in the major, all the triads, that is both all the three: host, fungus, as well as in environment. In the host factor, we are seeing the new risk factors. Now this liver cirrhosis has become a new risk factors. Even COPD, we are finding this chronic pulmonary aspergillosis, and more immunosuppression is being given in unrelated, and also like this pandemics. So even in COVID-19 situation, you have seen that viral infection has become earlier we knew that only influenza associated aspergillosis. Now this COVID associated mucormycosis, COVID associated pulmonary aspergillosis, COVID associated has become a standard term, and you all know about the unprecedented increase of mucormycosis in these patients. Also the fungus, in fungus wise, the spectrum is being changed. Now we are seeing the more number of this Candida auris, which is multi-drug resistant organism. And also in the environment, you all know that construction and natural disasters are all responsible for this changing in environment. So overall, the concern about this fungal infections. So it is mainly the AIDS physician, hematologist, and transplant doctors, internist, intensivist, and pulmonologist and surgeons, especially these general surgeons, where we see large number of pancreatitis, as well as this ENT surgeons, as even in ophthalmologists. So we need to have the improvement in the diagnosis is the first step for the appropriate management of the invasive fungal disease. So we need to have a panel of this one to for diagnostic facilities to improve the diagnosis. So how we can improve using this conventional technique? So we all know that everywhere all the biomarkers, PCRs, and all advanced machines were not available. If you think only about it in smaller institutions and other places, so in sample collection comes to one of the most important aspect. So because if the clinicians become more aggressive in collecting the samples, such as doing an invasive procedures such as CT guided FNAC, lung biopsy, and bronchoscopy, then larger number of this one diagnostic can be done. For example, during this COVID time, so our pulmonologists used to do a broncho earlier. They never used to do in the first wave, and second wave they started doing bronchoscopy, taking the precaution. Because of that, from the ball we could diagnose many cases of pulmonary mucormycosis, COVID associated pulmonary mucormycosis, which helped in exact treatment and then recovery of many of the patients. So aggressive this one sampling from clinicians is essential for an improvement in the diagnosis, as well as in the microbiology, as well as in an histopathology. We need to improve ourselves. So in histopathology, in situ hybridization, nowadays we have a kit for an aspergillus detection in situ hybridization, but still it is in very early stage. And molecular methods such as DNA extraction and PCRs, many commercial PCRs have been available. So many a times when the sample is not there, fresh samples, even from formalin fixed samples, you can try to identify the species so that appropriate antifungal agents can be given. So this is another thing that has become this T2 magnetic resonance, because every clinician will be interested. That's why, though it is not there in India, so everybody asks about what is this T2 magnetic particles. That's why I've included this particular slide here. So it is an blood culture. It is an alternative to blood culture. Means it is compared to BACTEC. You can see that that turnaround time is about in 2 to 3 hours. Directly from the clinical sample you take, and this is a nano-based PCR-based machine. Using a nanoparticle, it will detect the signals, magnetic signals, and give the signal. Based upon that, you can identify 5 different species. So because of its rapidity, it has become very famous, and in US and many of the European country, it has been there in the routine use in many of this mycology laboratory. But the problem is it can only detect 5 different species, but the major 5 species of Candida it can identify. But we do not have an isolate for this, because it is an doing PCR. We will not have culture for doing an susceptibility testing. And MALDI-TOF, you all know, I don't know, I didn't hear about earlier lectures. So you all know, but it has become and revolutionized even with the identification of the fungi. So you can see that earlier we used to take about 3 to 4 days for identifying one yeast. Now you know that within an half an hour, when you have a pure culture, you can identify your yeast. And also it has been used for doing even in the antifungal susceptibility testing. It is giving the clue, and also for the molecular typing. But only thing is there is a need for improvement in the local database. If you are using, you have to enhance your local database in order to improve the identification. So but what would be the real success? For example, you know that what are the current diagnostic techniques that is available can detect an infection, especially clinical infection, as well as pathological infection. So biological infection will be much earlier. So what is our target is we need to identify more and more number of cases with this biological infection. For this, we can so that we can use a targeted prophylaxis or preemptive therapy. And these are the particular tests that are available majorly for the Candida as well as Aspergillus, all the biomarker tests that is available. So it may be the PCR or glucan detection, as well as this Candida. You have both this mannan antigen and antibody detection, whereas for Aspergillus you have galactomannan detection and LFT, and also we have this beta D glucan, but it is I'll come to it. So these are the existing benchmark test that is available. CRP and prolactin. It is an indirect marker. So, but still we will have some clue about it, about the Candida infection if these things are mildly elevated. Serum galactomannan from the BAL, well standardized. Serum beta D glucan, but we need to have an expert interpretation has to be done with the levels of the when the result that is obtained. So newer biomarkers, Aspergillus PCR. Now you know that IDSA has included in their guideline. You can use Aspergillus PCR as one of an factor, microbiological factor for the diagnosis. So earlier it was not included in the guideline for diagnosis. So PCR and galactomannan. Now we have an Aspergillus lateral flow assay. BAL galactomannan is being evaluated. Still, we need a lot to do about this. Mucorale PCR from the blood, especially because pulmonary samples will be difficult, and also many other newer tests have been developed. First, coming to an beta D glucan assay. So you all know that it is present mainly when the most of the fungi, including this Aspergillus, Candida, Pneumocystis, Coccidioides, and Histoplasma, but it's not present in Cryptococcus and Mucorales. So this particular test can be used just to rule out an fungal infection or to rule in an fungal infection. So we have many different kits. So you should be cautious while purchasing the kits for beta D glucan. Now from Chinese market and other many have come, but you know that only one FDA approved kit is the Fungitel kit. So the cutoff value here is different for different other kits. So this is the one which has been very well evaluated and many trials have been done. So the interpretation will become very easy when you use this particular kit. So it is mainly used for the diagnosis of candidiasis, aspergillosis, as well as pneumocystis carinii pneumonia. So the performance, you see that it is very, very good when you use for all this one. So about more than 80% sensitivity as well as specificity. So this particular test, this beta D glucan, it is not particularly antigen. It is just like an LAL-based test. LAL test, it is which we use to detect an endotoxin. So it can detect 9 days before radiological signs appears. For example, in case of aspergillosis, and 10 days before the clinical diagnosis, and even in case of intra-abdominal candidiasis, you see that it can detect 5 days before the confirmation of the diagnosis by other method. And it has got an excellent negative predictive value, and also this can be used for to institute an preemptive antifungal therapy. And also you can identify therapeutic or prophylactic failures, especially in the recent data suggests that it can be used for detect the failures in this one. So Fungitel, what the test format that was available earlier or even now most commonly used is the Fungitel, which comes as a 21 thing. So turnaround time will become, because the cost of this one is when, for example, so when we in our this one PGI, without costing for manpower and other thing, it cost about 5,000 per test. So whereas if you go for an private labs, in the private labs, it is more than 10,000. Some also charge 15,000. And also we need to wait for about 21 samples you have to collect. So the purpose of rapid diagnosis will be lost. So now they have come up with an fungistat. So this can be done even if you have a single sample, you can do the test. And the sensitivity and specificity is comparable to the standard this Fungitel test. So this is Fungitel stat, but instead of giving a picogram value, they are giving it in galactomannan, beta D glucan index, like galactomannan index, what we do for an galactomannan. So this is being now even been available in India, and definitely in many of the private setups, it will be of more use. So galactomannan assay, again, this is mainly earlier it's mainly told it is specific for aspergillus, but if it is it can also give detect this histoplasmosis as well as fusariasis. It has got an high specificity, and negative results, if it is there, does not exclude the invasive aspergillosis. And also there is a necessity of regular monitoring of a series of sample to do it. So this galactomannan lateral flow assay. Now, instead of galactomannan, again, it is an ELISA test. It has to been done in a microbiology lab. and technical expertise are required. So this is a lateral flow assay which has been there to detect this is from IMI. So you can see here that with the different cutoff values as suggested, so equal sensitivity and specificity is very high, and it can be done in the side lab of a clinical. So this is very helpful. Another test that has been coming up and available even in India is this lateral flow device. This one does not detect an galactomannan, but it is detects an glucoprotein. So again, this is a very rapid test, and it can be used in conjunction with other PCR test to confirm the diagnosis. So it is said to be better than galactomannan as in screening test rather than confirmatory test. So when you are going for screening in an high risk group such as febrile neutropenia, this particular test can be very useful. So you can see the performance of this test. So especially in case of ICU settings, because of the increasing this invasive aspergillosis in ICU, so this kind of simple test, LFD, can see it can pick up about it. Sensitivity is about 79% and specificity is 85%, and negative predictive value of 96%. Really, it will help in reducing the antifungal use in an ICU setting. So obviously, in other settings also, it has been evaluated and shown to be very useful. So when you are doing this galactomannan and beta-D-glucan test, so prescribing the test, so which patient should be tested? That is a very important factor in order to appropriately use this particular test for the management purpose. So if you are ICU, so you should know an local epidemiology. So what is the, for example, if you have an candida, which species is circulating in your hospital, and what is the susceptibility pattern? So those things and all will differ. So wherever, if for example, in case of hematological malignancy, so invasive aspergillosis is definitely expected to be more than 10% in any setup. So there, if you prescribe this galactomannan and beta-D-glucan, false positivity will be less and negative predictive value will be very high. So there it will help. So when the patient is having an concomitant radiological sign, for example, in case of aspergillosis, he also has a classical radiological sign indicating that it is strongly indicating fungal infection or aspergillosis. There you can use it for diagnosis of for confirmation of the diagnosis or for the diagnosis. Whenever the incidence of an invasive aspergillosis is very low, for example, in case of solid organ transplant patients, their positive predictive value will fall below 20%. So false positivity results will be very high. So this particular test, both the beta-D-glucan and galactomannan, should be prescribed whenever the pre-test probability is really high, as in neutropenic patients or cancer patients, and then compared to rather than these ICU patients without any clinical signs. So current diagnostic test, so you know that I told that antibody test only for histoplasma and candida mannan antigen antibody is there. Whereas for biomarkers, you have for all aspergillus, cryptococcus, histoplasma, mucormycosis is well established. PCR is there in mucormycosis, and for candida again you have PCR and other stuff. So now coming to an antifungals that has been used. So you all know that now antifungal armamentarium is very less. So mainly we have these azoles, amphotericin B, flucytosine, as well as echinocandins. So most of this classical, they had effect on these echinocandins, this cell wall as well as plasma membranes. But now we have plethora of many new antifungals, which is being there in advanced stage of an and advanced stage of trials, and they're all in the pipeline, and shortly we may have those antifungals. So but still, what currently we are left with an azoles such as voriconazole, posaconazole, fluconazole, itraconazole, as well as echinocandins, 3 echinocandins, and amphotericin B, also this flucytosine. So strategies of antifungal strategies, you all know that one of main thing is an targeted one or the specific one. Here, when you isolate it from the clinical sample, biopsy samples, so it is classical that, okay, it is an proven cases, and then along with that guidelines, now we have proven probable and specific treatment can be given. So preemptive therapy, this has become a very important thing. So this is a diagnostic driven therapy. So preemptive. I'll come to it. The some of the studies that where this particular thing will help in reducing the use of an empirical antifungals. Empirical antifungals is the most commonly used in most majority of the setups. So even in ICU settings as well as immunosuppressed and febrile neutropenic settings, it has been mainly used. Prophylaxis, again, prophylaxis, you can do prophylaxis mainly has to be done in an high risk group. Mainly you can do it in a very high risk group, and when you have an fungal infection rate is very very high, more than 15%, if you have, then prophylaxis can be thought about. Otherwise prophylaxis does not have a major role in an setup where we have very very low this one. So how can we use this beta glucan test to discontinue the antifungals? So here is one of a classical study that has been done. So the number of cases is very very less. So when you see, they have shown that they have used this 21 different. They have shown that all the 21 patients in this particular this one who had the baseline negative, so they discontinued the anidula fungin on the day 4, and then they watched them unto 30 days and they did not see any development of an candidemia in those patients. So here what they say is, so early discontinuation of the empirical echinocandin therapy in a high risk group patient based on a consecutive negative beta D glucan. So single beta D glucan is not of much useful. So two different beta D glucan consecutively, if it is maybe a reasonable strategy. So at least you can prevent an overuse of an echinocandins in case of an ICU setting, especially for the candida diagnosis. So again, another study, this are we really ready with the candida biomarkers? So all other than this beta D glucan, you have other biomarkers, mannan as well as beta D, this candida albicans, the candida albicans germ tube assay, so which will detect all different candida. Name is candida albicans, but many other candida species also it will detect. So when they have tried to look into the colonized area as well as low colonization, high colonization, without colonization, intra-abdominal candidiasis and candidemia, you can see that increasing rate. And here, if the patient is having high colonization and this one, so again you will have a very very less margin. So at least what they say in this is, single assay if you do, so it is highly non-specific. So about 80% will have a positive results if you do single assay like this. So if you can combine the test with the two different one, for example, candida germ tube assay and candida beta glucan, so in a single blood sample. So if you do in a single blood sample, then the possibility of infection is really more. So even you can use beta glucan two consecutive blood samples. It will allow to differentiate colonization from an infection, invasive infection. But sensitivity is still low in a very high risk group. That is about 30% of the cases is still you are missing in the diagnosis. So a negative test does not rule out the candidiasis in a high risk patient. So now coming to an diagnosis of invasive aspergillosis, again here the strategy is you have to use the combination of the thing. So for example, PCR when you are using in combination, you can see the galactomannan as well as in case of combine PCR and galactomannan. So the sensitivity has really increased very very high. And you can see that when this glucan and PCR, can it be really used for screening of the patients in these high risk patients? So what does this meta-analysis says? So you can use these combinations. Two PCRs, you have a specificity of 93%. So two GMs, you have 95% and 62% sensitivity. GM and PCR, again, if you use one galactomannan as well as one PCR, you have a good sensitivity as well as good specificity. So for screening purpose, you have to do weekly screening with both of this one. So no positivity, invasive aspergillosis is unlikely, and one positive galactomannan or PCR cannot be confirmed or excluded. So you should have two tests to have an highly likely aspergillosis. So whether this antifungal agents, this one antifungal agents antifungal agents for preventing fungal infection in non-neutropenic this one. So in non-neutropenic, they have done a meta-analysis, and they have shown that here empirical antifungal use did not significantly reduce or increase the this one mortality. So whereas in proven group, when they analyzed, so there is a low grade of evidence of reduction of an invasive fungal infection. So for echinocandin therapy, they suggest that still high quality therapy, this one clinical trials is required. So is a preemptive antifungal strategy a good alternative to empirical therapy in a prolonged febrile neutropenic patient? So here what they have used is, for a preemptive therapy, they have used different markers. They have used biomarkers. They have also included this the CT as in one of the things, CT, galactomannan, PCR as they have used, and all this test multiple meta-analysis they have done it, and here they have shown that reducing if we use a preemptive therapy, it helps in reducing the mortality. So certainty of the evidence is really very low, but at least one thing, reducing the use of antifungal, the certainty is really very high. So the preemptive approach is better than empirical approach. So because at least in order it will help in reducing the use of an antifungal, but it is very difficult to balance the benefit, risk, and the cost due to the high level of uncertainty associated with the existing evidence. So we need to have more trials about this. So in case of hematological malignancy, when they did this cost analysis, especially in this preemptive therapy as well as empirical therapy, so you can see that preemptive therapy significantly lowers the antifungal exposure without any increase in the invasive fungal disease, and also without any increase in the overall mortality as in aspergillosis associated or all cause mortality. So but the cost definitely reduced than the empirical therapy. So either whether we could have another study in hematological malignancy, when you use this a standard conventional technique as well as an biomarker test, we can see that biomarker test mortality, when you use this biomarker test, so you can have an lesser mortality compared to an standard conventional diagnosis. So even if you use a biomarker, you are identifying more number of cases, at least 40% more number of cases, and antifungal institution can be given for the invasive aspergillosis. So biomarker use will be, if you are not starting, you should start using the biomarkers. So biomarkers can also be used to help in monitoring the therapy also. So here just when you compare this beta-D-glucan and galactomannan in combination really significantly helps in combination. But only beta-D-glucan, we do not have very good data, especially for aspergillosis, to monitor whether the decreasing will help in the monitoring the therapy or not, improvement in the patient condition. So galactomannan alone or galactomannan index also can be used very successfully for the monitoring the patient. Lastly, coming to the what are the challenges. So biomarker, is the biomarkers available helps in the diagnosis of all the fungal infection. So that too, it will it help in an early fungal infection, how much it is helping in early diagnosis. So these are all, there is still we need to do many clinical trials about all these challenges that I'm talking about in this last slide. So the impact of biomarker and the outcome again needs to find out what is the exact survival, so invasive fungal infection incidence and the cost. And pre-empiric therapy is presently mainly on not the same. So earlier it was purely on the fever based, and now it has been combined with CT and GM. So how exactly we need to utilize this test in part the therapy we should study. And in case of initiation of antifungal therapy, especially in an ICU settings, usually it has been become delayed 1 to 3 days, because people will evaluate about for fungi, other bacteria and other thing, and biomarker in case of compromise such as neutropenic patients, so aggressively they start diagnosing very early. So that's why in case of critically non-neutropenic patients, definitely we should have some guidelines when exactly we should send for an biomarker test. So again, endpoint is very difficult. So hematologist, they would like to give an antifungals and be happily sleep there. So that biomarkers and CT can use help this one. And another challenge is how to declare the fungal free. What is the exact endpoint when to stop an antifungal? Still, we need to have an again prophylaxis is a major problem. We do not have exactly the data to suggest which are the patients that we groom. And also in aspergillosis, another major problem is if you prophylax with the mold active agent, so you will have a decrease galactomannan level. So that is a major problem. So antifungal start may not be decided by the biomarker itself, but with the pulmonary system symptoms for an invasive aspergillosis. So with this, I would like to thank all of you for your kind attention, and I would like to answer any queries if you have, either offline or online. Thank you very much.
Thank you so much, sir, for your beautiful insight into antifungal stewardship. I request the delegates to put in your queries in the chat box below. As we are running 14 minutes short of schedule, I would like to invite Professor Manisha Biswal for the next talk. The topic for her talk is Role of Source Control in Preventing Infections with Multi-Drug Resistant Organisms. Dr. Manisha Biswal is currently working as professor in the Department of Medical Microbiology, PGI MER Chandigarh. She's actively involved in the hospital infection control at PGI. Her areas of interest includes hospital-acquired infections, hand hygiene surveillance, scrub typhus, and other neglected bacterial infections. She has been actively also involved in the antibiotic stewardship of this premier institute. Over to you, ma'am.
Hello, good afternoon. Can you hear me?
Yes, ma'am.
Okay, so I'm going to be sharing my presentation. So source control in hospital-acquired infections. It is, thank you for inviting me for this CME. And there can be no antimicrobial stewardship without decreasing the rate of hospital-acquired infections, as everybody knows. It is, the sources of nosocomial infections can be quite mind-boggling. As you see in Indian settings, we have patients. These are the common scenarios that you can see your patients, and infection can come from many sources. Okay, we will go into this little bit in detail. It is impossible to go into any of these subtopics in detail, but I shall be touching upon these points. We can discuss over the chat later on. So healthcare workers. So we know that the hands of healthcare workers are the primary source of many hospital-acquired infections. Hands can carry up to 10 to the power 6 CFUs per centimeter square of hand. That's like 1 million organisms per centimeter square of hand. Not all of them are things to worry about, but the pathogenic organisms that we carry in the hospital are the ones that we want to decrease. If a patient is infected or colonized with any organisms, when we touch this patient, we carry these organisms on our hands. And these will subsequently grow over time on our hands. And then if we go from patient 1 to patient B without performing hand hygiene, we are going to be carrying these organisms over. So it seems like a very simple thing to do. It's a very logical thing to do. Clean your hands before touching the patient. However, it is really surprising that we are still worldwide, we have figures like 40%, even in the best hospitals. This is PGI data. I'm showing a spectrum from 90% to something less than 10%. So we see the figures in red are the emergency areas. So these are the areas where the patients present first, and these are the areas where the devices are inserted, etc., etc. So we have a huge amount of work to do on hand hygiene. So patients deserve clean care. So hand hygiene campaigns, we've been conducted very commonly on the 5th of May. Many hospitals do this. Patients and healthcare workers should be empowered. They should be involved in the process. Badges should be given, and bare below the elbow policy should be enforced in many areas, and everybody should be involved in this, starting from all the healthcare workers, not just the doctors and nurses, all the subcategories of healthcare workers that come in contact with your patients, and including patient attendants. You know, this is a trend that is very common outside, where all the lay patients also are educated about hand hygiene. In India, it is not so. Little bit it has increased after COVID, etc., but this is a major population that also needs to be trained. So hand washing, the steps, etc., is what everybody knows. What we need to emphasize in our training sessions is removing hand articles, concentrating on the areas of the hands that are missed during hand hygiene, and also the moments of hand hygiene. So moment 1, 2, 3, 4, 5 might be they will increase, but moment 5, that is the after patient surroundings, people usually miss, thinking that is not important. So whatever it is that in your setup you feel is the gap is what you should be emphasizing on in your own setups. The glove use is very common. This is used as a substitute for hand hygiene. Many people wear gloves throughout the entire shift. It is not required. We have seen that gloves carry pathogenic organisms, and these are the ones that we see in our patient reports. So gloves usually prevent somebody, or they discourage somebody from performing hand hygiene, and so this is a major risk to development of hospital-acquired infection. This is some data that I'm showing from our hospitals. Healthcare workers can also have infections that they can transmit to patients, respiratory infections, skin infections, etc., etc. if hand hygiene and other precautions are not taken. And we should be vaccinated against all the infection that can be transmitted from person to person. Patient hygiene, some patients are downright dirty. There is no cleaning in busy settings. There is no manpower attributed to this. But if samples are taken, like in this patient, it's quite obvious. We saw Klebsiella pneumoniae in one sample that we took from the central line insertion site. So patient hygiene is important. Now there are many studies that are I'm sorry, are recommending chlorhexidine body wash to decrease the load on the skin where devices will be inserted, and they have shown a decrease in hospital-acquired infection after this. Coming to devices, they are a major source of hospital-acquired infection. They should be limited or discontinued. And bundles, there are bundles of all of these devices, which everybody knows. I'm not going to go into them in detail. I would like to emphasize on this scrub the hub technique here. This is known that scrubbing the hub for 10 to 15 seconds is going to decrease organisms on the hub before we manipulate the line. And single-use spirit swab should be preferred to this. And along with hand hygiene, a scrub the hub audit should also be done in your ICUs to look at this practice, along with daily observations of lines and flushing. These are very important points. I'm just touching on them so that later on we can discuss if necessary. Coming to VAP, this is the other major device in many hospitals, in many hospitalized patients, and devices like, apart from aseptic insertion, etc., in the bundle, these small practices like leaving the suction in the normal saline bottle to be used for the next suction, etc., because we don't want to increase the cost for the patient, are absolutely not cost effective, and they decrease the incidence of VAP. Things like not having humidification in the air that goes into the patient lungs, either a humidifier or an HME should be used, but in many settings this is missing. These are the things we should look out for. These are major sources of hospital-acquired infection. Coming to IV lines, we know there are many outbreaks that have been responsible because the outbreaks that have occurred because of contaminated blood products and other infections. So you see things like this. An entire normal saline bottle is opened in the morning and injections are made dissolved from it from the beginning to the end, and there are pre-dissolved preloaded syringes that are kept in settings, and there is no date, there is no time on them. Nobody knows who's made it and for how long it has been there. However, it is going to be injected to the patient. And line integrity, line security. So we have blood stained in the hubs and the blood stains in the ports, etc. So this will get contaminated. Wherever there is blood, it is going to get contaminated with organisms. So flushing is a must, even in peripheral lines. And needleless connectors are better than these hubs. That should be encouraged in practice. There are other IPC mistakes. You should look out for them. Sterile, this, for example, the laryngoscope blade is supposed to be sterile, it should be covered. However, there are other instruments lying on it, and a phone was charging on this before we took a photograph. So this is no longer sterile. If you intubate with this, then the patient will get a VAP. Then bottles are pricked with needles, and the needle just stays in situ there. This is the route for it to enter. Spirit bottles, instead of having a proper dispenser, just a hole is made. So if you remember this, that the pink color water is all going to be left behind, all the alcohol is going to evaporate because it is by default, that's the property. Same for storing anything in spirit. The alcohol is going to evaporate. What this is, you are storing it is in only colored water. The same for spirit swabs, all over they have anything and everything is used to make a spirit swab and store it in. So remember, the alcohol evaporates. What's left behind is only moist water. Fridge, refrigerators, they used to stock everything from medicines to food to patient samples, etc. There is mixing inside refrigerator, and that can lead to contamination of sterile products. So fluid warmers, instead of having dedicated fluid warmers, which are available in the market, they used to um, warm up water and put these fluid bottles. The water is contaminated, and the outside of these bottles also is going to get contaminated. So these are some medicines racks, stocks, cardboards which are stocked on the floor. And whenever there is a mopping or brooming going on, then a lot of contamination with dust, etc., is going to be landing on these bottles. These are small things that will be there in your setup. You have to look out for these mistakes and make sure that they do not, and change this so that they do not remain as a source of HAIs. Coming to environmental controls like air and water, you know that many infections are airborne. Commonly, you'll have fungal infections and back in TB, and apart from that, viruses like chickenpox and measles, which are airborne. So for them, there are transmission, there are precautions that every individual needs to take, and also institutional precautions, like for example, having HEPA filters installed in special areas, like positive pressure areas where patient is immunocompromised and needs to inhale only clean air, or negative pressure areas where the patient is has an infectious, highly infectious disease like an MDR, XDR, TB, or an Ebola virus, etc., where he needs to be negative pressure. So these are special ventilation areas. Air is also important in OT, where there are certain parameters that have to be followed: positive pressures, air changes, temperatures, humidity, etc., and a laminar flow system is recommended. Although there are many studies now that are contradicting this, saying that is not as important as the other basic precautions. For TB patients, we have so many of them in India. These are the precautions. You should postpone any active elective surgery or intubation, extubation till the last that you can. It should be a single case or like on a Saturday or something. Or and the healthcare workers need to be using at least an N95 respirator while intubation or any airborne aerosol generating procedure in on TB patients. This is sometimes ignored in emergency settings when we have many TB patients. People are just moving around in cloth masks, or people are moving around in the single layer surgical mask, etc., which is not enough. That becomes a source of infection. Water. Many infections can be caused by water. It's classically Legionella, but there are many of these gram negatives that are commonly causing HAI in our setup can be transferred through water. And non-tuberculous mycobacteria can be transferred by many sources of water in hospital. There are guidelines that say what kind of mycobacteria should be there for what fluids. So these are if one wants details, it should go into these guidelines. Coming to sterilization and disinfection, devices, are divided into so many types. So whatever is critical, for example, surgical instruments, etc., they need to be autoclaved, they need to be sterilized. We have seen so many things, so many times contamination of equipment, which is say ready to use, but growing some organisms. So they have not been adequately disinfected, high level disinfected or sterilized. Similarly, for injections or needles, etc., that should go into the body cavity. This is in radiology. They have some complicated needles, etc., which they cannot. They say they cannot afford to use as single use, as disposable, so they need to. So whatever it is that they need to use, and this is very common, like for example, cheetal forceps, whatever can be autoclaved should be autoclaved, and whatever method we are using for autoclaving, we need to monitor them sincerely with chemical and biological indicators. There should be logs for all this sterilization equipment that is there in the hospital. Environmental services, this guy is very important. He needs to be trained and he needs to have adequate infrastructure to perform cleaning of the hospital environment, the HAs and the SAs that are there. The role of cleaning disinfection cannot be underemphasized. We know this, and we had multiple studies during this COVID pandemic where pre-cleaning we had the organisms, and post-cleaning it was all gone. So the role of cleaning cannot be overemphasized. There are these high-touch surfaces that need to be cleaned again and again. And after the patient is discharged, the terminal cleaning has to be thorough. What to clean, when to clean, and how to clean, these are all very nicely given in so many guidelines. And then in Indian specific guideline, we have the Kaya Kalpa guidelines. They show in detail how to clean the floor, how to clean the other surfaces, what to use and when to discard, mops, etc. The monitoring of cleaning is not done very commonly in our Indian setups. This is an incubator and there's a date put in one of the pediatrics wards on when it was cleaned and when the next date for cleaning is due, depending on the logistics. This is a very good idea where it can be implemented. However, many times people just don't know when one particular thing was cleaned or not cleaned. Biomedical waste disposal, everybody knows about this. This is one of the most important tenets of hospital-acquired infections. Things have to go into their respective bins. However, you see this setup, everything is discarded into whatever bucket is free, whatever the person feels like. We have so many setups. This is pictures during COVID pandemic. So disposal is not proper at all. So the person who's going to clean up this mess is exposed to, very heavily exposed to the virus. So these are situations that we should be avoiding. Shops, many times the shop bins are overflowing. And even though there is a big hole in this thing, the shops, etc., will be discarded right next to the hole, not inside the bucket. So this is not logical at all. So somebody who's picking up these sharp pieces, etc., is at a huge amount of risk. So these are small things, but they go a long way in creating huge trouble for everybody. These are guidelines. They should be put up, pasted very prominently so that somebody who doesn't know how to read and write also can look at these pictures and then dispose things off in the right bin. Food, hospital food, people who are colonized, for example, typhoid Mary, can transmit certain organisms to patients. So kitchen staff needs to be clean. They need to take precautions that they do not spread infection, and they have diarrhea, etc., they should stay at home. This is not documented in many places. They just simply come to duty without taking antibiotics or keep on working throughout sick period. There are definite guidelines for what equipment to use, for what kind of food and how to store food and how to heat and reheat food, which need to be followed very strictly in hospital settings. Apart from the basic cleanliness, that is a mandatory thing in hospital kitchens. These are not photos from PGI. That's a disclaimer. These are photos from the internet, but kitchen cleanliness is something that should be on the checklist of infection preventionists. Then the sources and outbreaks also need to be investigated. We had one Auris outbreak, Candida auris outbreak in one ICU. We had one index patient, and then it spread to 3 other patients, and then it went on. When we investigated, we found many patients who were colonized and a lot of hospital services which had been contaminated with Candida auris. And what was interesting here was that we had a lot of patients who were almost 90% of these patients were colonized in the axilla. When we started looking at the source, we found the ECG leads and the temperature probes that are classically placed in the axilla of these patients which were contaminated. So normally they're supposed to be sent for high level disinfection for ETO sterilization or high level disinfection, but they just to in the interest of time, they were just sprayed with alcohol and left to dry. It was not being meticulously cleaned and it stayed contaminated with Candida auris, which caused this outbreak. So once they started to be properly sterilized, we were able to curb this outbreak. There are many studies linking hospital environment to hospital-acquired infections, fungal infections. Many times, construction activities, you see clear graphs of infections with the peaks in construction activity. Then there are many hospitals. This was the investigation of fusarium, which occurred because of hospital water that was contaminated. Then there are fomites like adhesive tape, bandages, etc., where mucor occurred in hematology patients. We had in PJ also, there are bacterial outbreaks also here. We had a Klebsiella outbreak in neonates and a diarrhea outbreak transmitted through milk on an infected healthcare worker. And this is an example of a surgical site infection, which because of an atypical mycobacteria, although we could not find a proper source, we went in for hypochlorination of the water and the outbreak was curbed after that. So this is suggestive evidence that maybe the water had something to do with this outbreak. So you will also be having a lot of outbreaks whenever you are in hospital-acquired infection practice, I would recommend that you publish these investigations. In India, many outbreaks are not recorded at all, and this is a huge loss of evidence and a huge loss of knowledge for everybody concerned. We need to know what it is that can be a source. If it is a source in another hospital, then it will be a source in your hospital also. So we need to, the kitchen workers, the physiotherapists, everybody needs, the phlebotomists, the perfusionists and OT, etc., etc. All of these people need to be trained, and a log of training should be there and checked by IPC as to whether it's adequate or not. The second thing that needs to be done is all these infection control practices have to be monitored by whatever method, by checklist, by manual method, by app method, whatever. This is an example of an app that we're using for hand hygiene in PGI. It's called PD Audit. Some of you may be using it. So here you get a graph. Immediately after the session, you get the graph, and this is sent by WhatsApp to all the stakeholders. The infection control nurses send it to the nurses, and I send it to the consultants. And then a feedback system is established. And if you get an immediate feedback about what happened in the morning, then in the afternoon there is conversation in their groups about today this one missed and that one missed, and we need to re-emphasize this and whatever. A cycle, a feedback cycle is very important. And wherever this is closed, the cycle is made, and it brings the infection prevention people and the ward people, ICU people closer. And the feedback cycle is very important. Example of a QI group of ANSs in our hospital, where the daily audit graph is reported, and whatever is missing in that session is then reported, and feedback is sought from the nurses. It's working very well in this group, that we started out with very low hand hygiene compliance, but the compliance is on a steady trend of improvement. So these are the two things that need to be done continuously. One is training and one is monitoring. With that, I would like to conclude my lecture. I need to thank my infection control nurses in the Hospital Infection Control Committee of PGI for the data and the pictures that I have put in my presentation. So thank you. If there are questions, then we can discuss. I hope I finished in time.
Thank you so much, ma'am, for the wonderful talk. I'm sure your experiences of antimicrobial stewardship will help the budding infection control officers of the country. The delegates will be putting in the queries in the chat box, and ma'am can answer them there. Thank you, ma'am.
Thank you.
We now move on. Thank you, ma'am. We now move on to the most awaited event of the CME, the quiz itself. Now, just to get the adrenaline rushing, I want to announce that we will be having cash prizes for the quiz. Now, the undisputed first prize holder will get a cash prize of rupees 3,000, second 2,000, followed by 1,500, 1,000, so on. And there'll be 5 of them. And in case there is an overlap with 2 people having same scores, then of course the cash prizes will be redistributed. So I'll be soon sharing the link for the Google form for the quiz, and you will get only a time of 15 minutes to fill it. So please keep your eyes on the chat box, where soon you get the link. And by my watch, it's 12:30, and your time starts now. You may log in, you may click on the link and Another 5 minutes to go for the quiz. Last 1 minute remaining for the quiz. Well, time is over. I hope you have submitted your Google Forms with the answers. Now, the results of the quiz will be declared after the panel discussion. I now want to request all of you to kindly show your video so that we can take a picture of all of us together on this meet. Yes, I can see the beautiful faces coming up. Yes, let's wait for a few seconds so that all of us join in, and then I can take the screenshots for not just the attendance, but also for good memories. Video on the So, informally, so say cheese without your masks, please. I'm happy to see we have at least 140 participants right now. Okay, thank you so much. I've done the snap taking. Now we proceed to the third session for the event. For this, I would like, you may now close your videos, of course. Okay, so the first topic in this session is the menace of over-the-counter antimicrobials, a problem huge enough in our country. For this, I would like to invite Dr. Yangshin, who is Assistant Professor in the Department of Pharmacology at Aiims, Bilaspur. Her areas of interest include the antimicrobial stewardship, drug utilization, discovery, pharmacovigilance, material vigilance, and population pharmacokinetics. She has been actively involved earlier in prescription audit that was being conducted. She has been the coordinator of the Adverse Drug Reaction Monitoring Center and the NDMCMC at Hindurao Hospital. She has nearly 12 international publications and several other national ones to her credit. I invite her for the talk.
A very good afternoon. The topic for my presentation today is the menace of over-the-counter antimicrobials. So I've divided this presentation into various parts. So the primary objective of this presentation would be that to understand the burden of antimicrobial resistance, the severity of antimicrobial use, why there is an rise of over-the-counter antimicrobials in India, and what are the regulations which are already in place, and what solutions can we provide to curb this practice. So antimicrobial resistance, as already discussed, it's a global public health challenge, and it is estimated that by 2050, around 10 million people would die every year, primarily because of antimicrobial resistance, surpassing all the other causes of death. And this is a major cause of concern. This will have economic implications as well. And it is seen that 50% of prescriptions worldwide are sold without, 50% of antibiotics are sold without prescription. And it is one of the leading factors of antimicrobial resistance. And the major burden or major contributors are the low and middle income countries, that is, which includes the Southeast Asia and India. So in India, we are the largest producers of antibiotics, and we are one of the largest consumers. It was seen in 2010 that we were the largest consumption of antibiotic pills was in India, and it amounted to around 12.9 billion, which went up in 62% more. It went up by 62% more from the previous decade. So in 2000, from 2001 to 2010, there was a 62% increase in usage of antibiotic. So from this you can see the trend of rising use of antibiotic in India. And so also India contributes to the one of the highest burdens of drug resistant pathogens worldwide, and 1/4 of the global incidence of multi-drug resistant tuberculosis, it accounts for that also. There is rise of resistance to carbapenem in ICU according to the ICMR surveys, and there is rise of resistance to our reserve drugs such as colistin as well. So these are all warning signals that we need to do something about it. So the cause for antimicrobial resistance are many, but today I'll primarily cover this over-the-counter sale. So in India, we have this habit of popping a pill popping syndrome because of easy access. And this easy access is because anybody can buy an antibiotic and the pharmacist dispenses antibiotic without prescription as well. So that is the major cause of concern here, and which can be prevented easily. So these are the common trends. As you can see, there is a rising trend of use of cephalosporins and quinolones. And there is almost the rise of resistance as well. 77% of cephalosporins are resistant. This is a resistance map by the Center for Disease Dynamics, Economic and Policy. And this shows a decade graph of the resistance pattern, and it is on rise. So can you buy an antibiotic without prescription? The answer is no. So it is illegal. So despite being illegal, why is there a trend of buying and dispensing antibiotics over the counter? So there are various factors. There are pharmacist himself or the pharmacist. They also have commercial pressures, so to maximize their profit. And they know that the regulatory enforcement are poor. There are regulations. Some might be aware of the regulations, some might not. So they know that regulations are in place, but there is poor enforcement. Also, the pharmaceutical companies also influence their dispensing behavior by making it more profitable to sell newer or branded antibiotics. So the pharmacist gets a cut from the pharmaceutical company and he will promote a particular drug or a branded antibiotic. So these are the factors for which the pharmacist dispenses an antibiotic. Whereas from a patient's perspective, if you see majority, 70% of the population is in rural India, and they have poor access to doctors. So they have poor access to a registered medical practitioner. So where do they go first? They go to pharmacists. So pharmacist becomes the first point of medical care. Also in urban areas or urban slums, or just to avoid lengthy waiting time, because some of the in urban slums people are daily wagers. So going to a hospital in a government hospital will lead to a loss of 1 day's labor cost. So what we'll do, if he has certain fever, we'll go to a pharmacist, buy an antibiotic, and save time and earn money. Also, because he cannot afford, because the person is poor, he cannot afford to go to a private hospital because of high consultation fees. So these are the pharmacist and patient factors. Now, there is a huge lacunae or lack of awareness about antimicrobial resistance and the risks that it poses to the health of themselves that is the pharmacist or the consumer, and the community as well. So the patient might not know that what risk he is posing to himself in a longer run, because they are simply not aware. So there are regulations in place. As you all know, there is Drugs and Cosmetics Acts and Rules 1945, which says that Schedule H drug, which are antibiotics, can be prescribed only on prescription and not to be sold without prescription. But the laws, the regulations were in place, but recently there has been an amendment in the Drugs and Cosmetics Act, which says that which introduced Schedule H1, which included 24 antibiotics, such as the third generation and the fourth generation cephalosporins, carbapenems, anti-tubercular drugs, and new fluoroquinolones. So herein, the pharmacist needs to maintain a separate register with the copy of prescription. The register should have name and address of the prescriber, the name of the drugs and the quantity supplied, and the record needs to be maintained for 3 years, and it is open for inspection. It also states that this sign of take thou should be in red, and the prescription, the label should have a warning in a red box, which states that it is dangerous to take this preparation except in accordance with the medical advice. So there should be strict enforcement, and the government is working on that. Recently in Chennai, over 200 cases were registered against medical shops for violating law. 20,000 fine was the fine for the offender, and it is a offense which can lead to imprisonment also, which could be 1 year or more. So the pharmacist should not take this lightly, and there should be strict enforcement, and the state drug inspectors can inspect, can seize the drugs if there is any complaint against that particular pharmacy, and they can go on a regular inspection as well. So the number of inspections also need to be increased. Also, there are regulations on the pharmacist as well. So like doctor, the pharmacist also cannot or should not give or receive any gift or bonus for referring a patient, for procuring of any drug for the patient. And the State Pharmacy Council will appoint pharmacy inspectors, and they will inspect, inquire, and investigate. And they will submit the report to the registrar. The Government of India also, in 2016, it started an awareness campaign which states medicine with red lines. Like every antibiotic will have this particular red line, so as to indicate that this is an antibiotic and a prescription drug. So has to be taken only on prescription. So red signifies danger. There are national action plan on antimicrobial resistance as well. There are policies in place which was introduced in 2017. And this also emphasizes on surveillance of this OTC and identify unlicensed pharmacy, unqualified medical practitioners and prescribers. There are regulations, gray regulatory areas in accordance with e-pharmacy and internet pharmacy. But in 2018, Ministry of Health and Family Welfare also, they circulated a draft and the sale of drug by e-pharmacy. And they also need to maintain a record of the cash and credit, and they will be inspected every 2 years. So what are the solutions that we can provide besides the enforcement of regulation? What we need to do is we need to engage the stakeholders. We need to give them incentives. We cannot forcefully change behavior of people. The approach of top-down approach, both the top-down and the bottom-up approach need to be applied. So we can take examples or emulate from other countries. In London NHS system, they give financial incentives to people, to the physicians to reduce prescription of antibiotics. So if somebody is prescribing less antibiotics, there is financial incentive for that. Then availability of smart prescription tools, like availability of antibiotic prescription guidelines in your hand. Then in India, according to the national antibiotic policy also, it encourages the studies on antibiotic sales to understand incentives to sell and buy. So basically, study to identify the behavioral pattern of buying an antibiotic. And there could be accreditation programs, like we can give an incentive to the owner who becomes accredited that he would be legally authorized to sell a limited number of antibiotics. Like that particular pharmacy will be accredited to sell certain amount of antibiotics without prescription. Another thing that we can do, is we can enhance surveillance measures, more frequent inspections, and more frequent inspections of pharmacies and their prescription and sale records. And drug inspectors can also simulate client methodology to check pharmacist adherence to the rules. So the take-home message here is that we need to strengthen the national regulatory system and better implementation, as well as continuous awareness, both to the prescribers, the patients, and the pharmacists. So they need to understand the rules and laws of appropriate use of antimicrobials. Thank you.
Thank you so much, Dr. Yangshan. That's a pretty informative talk. The questions related to this talk can be addressed in the chat box. So I request the viewers to put in their queries there. Moving on, we move on to probably the last talk, though we have a very interesting panel discussion coming up. So the last talk of this event is the policies governing AMSP in India pertaining to our country. For this, I would like to invite Dr. Puneet Kumar Gupta, who is working as Associate Professor in the Department of Microbiology at Aiims, Bilaspur. So the keen area of interest has include hospital infection control and prevention, bacteriology and mycobacteriology. Dr. Puneet has previously worked at Aiims Rishikesh, Dr. RPGMC Tanda, and IGMC Shimla, and PGI also. He has more than 37 papers to his credit and has received various awards and certificates. I invite you, sir, for your talk. Thank you.
Good afternoon, everyone. First of all, I would like to thank organizing team for giving me opportunity to say few words in subsequent 10 minutes talk regarding the policy governing AMSP in India. The journey of AMSP in India started in 2011 with AMR, Jaipur Declaration on AMR in 29th Health Ministers Meet of Member States of WHO Southeast Asian regions. They said to adopt a holistic multidisciplinary approach towards prevention and containment of AMR to improve the public health. Acknowledge AMR as a major public health issue, a coherent, comprehensive, integrated national approach is required. Develop a national antibiotic policy, formulate multi-sectoral national alliance against AMR, multidisciplinary approach at government and private health sector is required. There is a requirement to study emergence and spread of AMR and assess its impact, and others measures in the form of capacity building for efficient surveillance, strengthening the diagnostic facility, regulating the non-therapeutic use of antimicrobial agents at various other sectors, encouraging support, basic and operational research and other things, and development of international and national regional mechanisms for regular data sharing. Further, in 2012, Chennai Declaration was held, where a roadmap to tackle the challenge of antimicrobial resistance was made by joint efforts of various societies of Medical Society of India, along with representative from WHO, National Accreditation Boards of Hospitals, MCIs, DCGI, ICMR, where they said that it is not time to look back, but rather to look forward and make joint efforts to tackle the problem of AMR in India as well as internationally. Thereafter, global action in line with Global Action Plan AMR 2015 National Action Plan AMR 1721 was developed with these 6 main focus area of awareness, understanding by means of communication, IEC, education, training, increasing knowledge evidence by strengthening laboratory surveillance, strengthening of AMR in human, animal, and environment, in IPC activities in various sectors, optimal utilization of various antibiotics in various areas, innovation and research development by better financing and better innovations, then leadership enhancement at the level of by means of collaborations at state, national, and international level. There exist various national networks for AMR surveillance, HAI surveillance, and antimicrobial stewardship, which are managed by various bodies like NCDC, IC, MR, CDC. Among them, National Program on Containment of Antimicrobial Resistance is one of them, which is currently operated at various 30 centers in 24 states of India. Other than this, national treatment guidelines for antimicrobial use in infectious diseases, infection preventions and control in healthcare facility guidelines is given by NCDC. Various IC activities, review meeting, training, workshop, strengthening laboratory capacity for AMR detection are being done by NCDC. Antimicrobial resistance surveillance research network is another network by ICMR, where the main goals are to establish a network of hospitals to monitor the trends of AST profile among the clinically important bacteria and fungi, include comprehensive molecular studies of drug-resistant pathogens, their dynamics of transmissions, disseminate information of AMR in pathogenic organism to all stakeholders, create data management system for data collection and analysis. Various centers in which it operates is CMC Vellore, Aiims, New Delhi, PGI Chandigarh, JIPMER against these various pathogens. Then another network is a capacity building and strengthening of hospital infection control to detect and prevent the AMR in India is through ICMR and CDC. It is managed at various levels in various hospitals of India, including the public, private, missionary, army hospital, catering to diverse category of patient population as shown in this map. And in this, surveillance against various healthcare infections is regularly being undertaken. Other than this, antimicrobial stewardship program guidelines was developed by ICMR in 2018 with primary goal to optimize safe, appropriate use of antibiotics to improve the clinical outcome, minimize adverse effect of antibiotic, and with secondary goal to reduce the healthcare cost without adversely impacting the quality of patient care, to reduce the incidence of antibiotic-induced collateral damage. So these goals meet the CDC definition indirectly in the form of right antibiotic for the right patient at right dose at right duration, causing least harm to the patient or the future patient. To implement this, you require various methodologies in the form of active strategies or other strategies. Active strategies, as mentioned by the ICMR, this document includes the prospective audit with intervention and feedback, which is a type of back-end approach, and the formulary restriction and pre-authorization is forend approach. Then other strategies includes these like switch from parental to oral, streaming and other things. So strategies which are required for antimicrobial stewardship program are active, supplemental and others. Active I have already enumerated. The supplemental include the didactic educations, Then clinical practice guidelines for the common infectious syndrome, which may be facility specific or maybe the patient specific. Then guidelines and the clinical pathways, then antibiotic cycling, antimicrobial order forms, then other strategies could be the antibiotic use measures, combination therapy, dose optimization, duration optimization, streamlining or de-escalation, switching from the parenteral to oral therapy whenever it is possible. The other strategies could be in the form of use of information technology like computer surveillance and decision support methodologies, improving the role of microbiology laboratory by strengthening them, improving the culture of cultures prior to start of the antibiotic. You should take the culture, round the clock facility for microbiology laboratory, use of rapid automated methods for early identification of the disease pathogens, providing AST at the earliest, selective and cascade reporting, test to rule out the bacterial infections, then rapid viral testing, non-culture based fungal markers, biomarker like CRP, procalcitonin, then improving the art of communications and reporting in the form of reporting at every step, not at the end reporting at the end. So report at every step, starting from the sample collection till final report generation. Use methodology for early dissemination of information, either laboratory information system or hospital information system. Then not only the all these activities important, but also monitoring is important. If you are not able to monitor the things, you are not able to show whether change has happened or not, whatever strategy you have applied, whether that is acting or not. So monitoring is very, very important. So monitoring may be at the level of processes or it may be at the level of outcome. Processes monitoring could be policy adherence, like in the form of de-escalation adherence rate, what is the rate, culture of culture, what is the rate, timely cessation of antimicrobial prophylaxis or antimicrobial usage indicator in the form of defined daily doses, days of therapies, or monitoring the outcome in the form of microbiological indicator, AMR rate, rate of Clostridium difficile infection, clinical indicator, financial indicator in the form of like in antibiotic cost per patient, per year, or per admission is required. So to implement these all things, a comprehensive multidisciplinary antimicrobial management program is required, which core component include leadership commitment, accountability, then accountability by appointing a single responsible persons in the form of a antimicrobial stewardship team, which consists of infectious disease pharmacist, ID clinicians, information system, IPC committee, clinical microbiologists, then drug expertise in the form of single pharmacist leader to improve the antibiotic uses, action in the form of systemic evaluation of ongoing activity, tracking them, reporting them, educating the all stakeholders. There are multiple strategies which are mentioned in ICMR document, and implementing all the strategies simultaneously is difficult. As I told you, the active strategy in the form of front end or back end approach, they are having the best level of evidence which is available against them. Against others, either the evidence is of low level or evidence is not available. So these are not only the implementation is important, monitoring is important, which strategy is helpful, that is also important. So identification of a problem or a issue is important, then setting up criteria or standards which you are going to implement is to be set up. Then observe the practice and collect the data, compare the performance with predefined data and see whether the change has happened or not, and re-identify the problem, re-identify the issue, and repeat this cycle of the plan, do, study, and act, that is PDSA cycle. So it's everyone's responsibility to act, not a single man responsibility. So everyone have to be together to implement the antimicrobial stewardship activity. So these are few of my references which you can refer. So this is all about the policies which I have to say. Thank you, everyone.
Megha ma'am, you are in mute. Can you please unmute?
Well, thank you for informing. Thank you, Puneet sir, for the wonderful talk. The questions related to his talk can be put up in the chat box, and sir will be happy to answer. We now move on to the panel discussion, and I invite all the panelists on board with their videos on. So I would like to invite Dr. Darwin Kaushal, Associate Professor, ENT from Aiims Bilaspur, Dr. Chitresh Sharma, Associate Professor, Surgical Oncology, Aiims Bilaspur, Dr. Nalini, Assistant Professor, Neonatology, Aiims Bilaspur. Then we have Dr. Anita Saran from the Department of Anesthesiology, Dr. Sushruti Kaushal from the Department of Obstetric and Gynecology, and we have Dr. Deepak Sharma, Associate Professor, Medicine from Aiims Jodhpur. Kindly join us all, dear panelists. Harshul, kindly switch on the mode wherein we can see all the panelists together. Harshul, can you hear me?
Yes, ma'am. Yes, ma'am.
Yeah. So also put on the PPT containing the panel discussion questions so that our viewers can check them out also. Yes. So we move on to the first panelist. The next slide, Harshul, please. Dr. Darwin Kaushal. So the first question. So these questions we have gathered from our audiences today, as well as in the days when we were preparing for the CME. So the first question that is pretty relevant in today's context is, sir, what is your opinion about the misuse of antibiotics in patients coming to the ENT OPD?
I fully agree with your first question. That is, nowadays there is lot of misuse of antibiotics, because what we have observed in our day-to-day scenarios is that almost all our patients have already taken azithromycin and in fact coamoxiclav also. And particularly after this COVID era, we have observed that majority of our patients, they have taken doxycycline, they have taken azithromycin and coamoxiclav. So yes, there is no doubt there is a lot of misuse of antibiotics, and two important I would say important complications we are able to see nowadays, that is antibiotic resistance, and yes, it is definitely affecting economy of our patients and nation as well.
Thank you, sir. So the next question is, do you routinely do swab culture, and what are the indications for it, especially in the context of ENT patients?
No, ma'am, we don't do culture sensitivity or swab culture in majority of our patients. And moreover, if I answer this question, the indication of culture sensitivity or to see type of organism is always in our non-responding patients. For example, there is a patient of chronic suppurative otitis media. So as a routine, we don't go for culture sensitivity. We do culture sensitivity only when patient is not responding to our conventional antibiotics. And moreover, there are some diseases where we are very keen to find out type of organism. For example, patient of skull base osteomyelitis, we want to see whether it is pseudomonas or some other bacteria. Or for example, in suspected case of diphtheria, we go for throat culture sensitivity. So I think indication for culture sensitivity or swab culture is in majority of a patient to see type of organism, and sometimes even culture sensitivity also guides us regarding which antibiotic to change or start. So this is indication in majority of our patients.
Thank you, sir. Well, this was my third question, in fact. So, what about the change of antibiotics after you have received the culture sensitivity report? Would you like to throw some light on that?
We don't go for change of antibiotics after culture sensitivity as a routine. So I think, ma'am, here important thing is if our patient is responding to our empirical therapy, which we have started antibiotics, so we don't go to change for antibiotics. But yes, if our patient is not responding, patient is deteriorating, we monitor with symptoms, and culture sensitivity has revealed some different kind of organism with antibiotic sensitivity, then yes, this is an absolute indication to change antibiotic. And here my message to all clinicians, whosoever is in this workshop, I think most important thing is always take culture sensitivity specimen before start of this empirical therapy. Otherwise, this is definitely going to affect type of organism and definitely going to affect culture sensitivity.
Thank you, sir. One last question, sir. So we've seen last year and even in this year, in the era of COVID-19, a lot of antibiotics were being misused. Fortunately so, or unfortunately so, even at the departments of ENT, because they were the first symptoms appearing in the patients. So, sir, by your experience, are there any specific protocols for antibiotics in the COVID-19 era?
If you ask me about protocol of antibiotics in COVID-19, I think, ma'am, whenever patient has come to us, patient has already taken majority of those antibiotics which were prescribed by our committees constituted by even government of India also. But yes, patient has taken, I have seen azithromycin, clarithromycin, doxycycline, ivermectin. So by the time patient has come to us, and we have seen that almost all these viral infections, they can be just observed, monitor for all those danger signs, and in majority of our cases there is no need for any additional antibiotic other than that, and in fact no antibiotic. So antibiotics can be given when patient has gone to some ICU setup, but yes, as routine ENT patients, majority of our patients, there is no standard COVID-19 protocol if you will say that this antibiotic has to be given. Otherwise, nothing we have followed like that, that these three antibiotics or these two antibiotics we will be giving to our routine COVID-19 patients.
Please. Yes. Thank you, Dr. Darwin. Thank you for such an insight. I now would like to welcome our second panelist, Dr. Chitresh Sharma, Associate Professor in the Department of Surgical Oncology, Aiims Bilaspur. Okay, sir. So the first question that we want to put forward to you is, it was also asked in the current one of the talks in the morning. So when in a catheterized patient, the laboratory investigations should be utilized, the urine microscopy and culture. When exactly do you recommend that?
Am I audible? Am I audible to you?
Yes, sir.
Okay. So thank you, Dr. Megha and Anuradha ma'am, for giving us the opportunity to discuss the important thing about the CME. So regarding your first question, the mistake we as a clinician we all are doing is we are searching or we are going for detecting the bacteria, but the researches and the studies shows that in a catheterized patient the incidence of bacteremia on daily basis is 3 to 8%. So by calculating every seventh day, the percentage of bacteremia is increasing 25%, and after the end of 25th day, almost all catheterized patient will have a bacteriuria. So that means in any asymptomatic patient, we should not prescribe the routine urine microscopy or culture, because if we are doing so, we'll get the bacteriuria in 100% cases. So the correct approach is we should select those patients who are symptomatic. And the symptomatic means the patient is having chills, fever, foul smelling urine, the cloudy urine, and the most important examination finding is the suprapubic tenderness. So that means fever with suprapubic tenderness, this is the most important indication for sending urine microscopy and culture.
Thank you, sir. So the next question I want to pose to you is that, are there different types of catheters which can be used for different durations?
Yes, Dr. Megha, there are catheters mainly of two types. One is the K90 catheter or intermittent and clean catheterization, and for indwelling catheters, most of the catheters are made up of latex, PVC or silicone. Latex and the silicone are the two most commonly used catheters, and the frequency or duration of use, if we are planning to use in a chronic patient or in a chronic situation, so we usually go for the this celastic catheters, and if we are using for short-term purposes, usually latex catheters are being used. Ma'am, I think there is a problem in audiovisual. I could not hear your question. Am I audible to you?
Anuradha ma'am, Anuradha ma'am, you are not audible.
Okay, we can come back to ma'am again. Ma'am, just give us a minute. Chitresha, so the next question that we have for you is, how candiduria should be managed in a catheterized patient?
Yes, Dr. Mega, the problem with candiduria is if we find these candid colonies in the specimen, they again the same thing. We have to see that if patient is symptomatic or not. The important thing is whenever we find this candiduria, we should remove the catheter and we should change the catheter. If even changing the catheter, if we are finding these candids in 2 consecutive day samples and the colony count is very high, if it is more than 10 to the power 4, then there should be a nidus or there is a focus of fungal infection, maybe in any in the bladder or in the kidney. So if we are finding the consistent candiduria, persistent candiduria, even after changing the catheter, we should go for the ultrasonography of the urogenital tract. And if we find that there is a fungus ball, then it should be removed by endoscopically or by surgery. And if there is no fungus ball, then we should treat this with amphotericin B. Because if there is a nidus or fungus ball, if even after giving the antifungals, the results, the amphotericin B is not going to cure or penetrate into these fungus balls. So the important thing is, if we find this focus of fungus, then we should remove it by surgery or endoscopy. Otherwise, we should treat this candiduria if patient is symptomatic. And we should change the catheter.
Thank you so much, sir. Thank you for your candor. So there's one question raised during one of the talk. So I would like to request Radha ma'am to kindly answer it regarding candiduria. Ma'am,
Okay. Am I audible? Okay. So, see, okay. So there is a, I think Dr. Harshad is unmuted, so we have a disturbance, so ignore it. He's driving probably. So we have a question that whether we should treat candiduria or not. So ITSA gives guidelines that for treating candiduria, there are only 3 conditions: prior to a surgical manipulation, in low birth weight babies, newborn babies, or in immunocompromised patients. Otherwise, candiduria as such is because of some high risk factor. Maybe patient is on prolonged antibiotic therapy, maybe patient has uncontrolled diabetes, maybe there is some urogenital obstruction, there is a benign prostate hypertrophy, or maybe in elderly because of incomplete emptying of bladder. So you may find candiduria, but as such, just presence of candida in the bladder, in the just causing means we can't even call it cystitis, just presence in the urine without any systemic involvement doesn't require treatment. It just needs management of the risk factor which is leading to it. So if risk factor is managed, it will disappear within few weeks time and no treatment is required. Now there's a category where the patient needs treatment, then we always must have a ultrasonography of the genitourinary system. Look for a fungus ball. If it's there, it has to be removed, because if it's there, then treatment will not work. Then people ask, do we need a sensitivity for candiduria? No, we don't need a sensitivity. First, you take care of the risk factor. Second, there are only 3 drugs which we can use for candiduria. One, fluconazole. Fluconazole is the standard drug which needs to be used. And second is low dose amphotericin B. If at all we require, then low dose amphotericin B should be used. And flucytosine. It can be used in combination with amphotericin B because it has a high concentration in the urine, but it has high toxicity. So we have to take care of the risk factors. They are more important. Okay, so this is how the candiduria is managed. Thank you.
thank you, ma'am. We now move on to our next panelist, Dr. Nalini. She's Assistant Professor in Neonatology at Aiims, Bilaspur. Ma'am, have you joined us?
Yes, ma'am. Can you hear me, ma'am?
Ma'am, the first question. Yes, ma'am. Yes, ma'am. So the first question I want to put forward to you is, what are the conditions in which antibiotics are prescribed in the pediatric OPD, rather unnecessarily prescribed? Please, ma'am.
Usually, we see the common conditions in pediatric OPD as people, parents bring their children with fever. Even for one day, they will bring to hospital or OPD setup, and cough and cold, ear discharge, skin boils. Sometimes they will come with loose stools. So these are the common conditions we see in pediatric OPD. But if you see fever for one day, it can be viral fever, it can be evolving into other causes. So what we have to do is we have to wait and watch here. So unless the baby is having danger signs, obviously if the baby is having danger signs, the baby is going to get admitted and appropriately the baby is going to be treated. Even for viral fever, we should not prescribe antibiotics. That's the one thing. So we should find out the focus and treat it. If danger signs, definitely admit it. So that is about fever, especially in this COVID era, which is a viral infection. For that also, antibiotics are being prescribed. Another thing is to prevent infection, like prophylactically, can we take the baby is having viral fever now, the baby should not have any secondary infections, can we give antibiotics? So these are the things which are coming to the parents' mind, doubts. So what we have to tell them clearly is counsel them, these prophylactic antibiotics are not going to prevent any secondary infections or co-infections, super infections. So that has to be instilled. So those are the conditions usually they prescribe antibiotics in fever. The next is cough and cold. Usually running nose, that is sinusitis, rhinitis, or it is streptococcal throat pharyngitis, or it is viral pharyngitis. So these are the common acute otitis media. These are the common upper respiratory tract infections. Most of them are viral in pediatrics. So if only few things like acute otitis media, if we take babies less than 6 months, definitely we are going to treat with antibiotics. Babies between 6 months to 23 months, if it is bilateral, definitely need antibiotics. Babies more than 24 months, 2 years, even if it is either unilateral or bilateral, we can wait and watch for at least 72 hours. If the baby is having danger signs, then obviously we have to treat with antibiotics. So unnecessary treatment of antibiotics in acute otitis media, and if you take in pharyngitis, we have to differentiate from viral and bacterial pharyngitis. There are center criteria is there for pharyngitis. We can put, if 2 or more is there, then maybe it is a bacterial pharyngitis, we can treat with antibiotics. Nowadays, rapid diagnostic tests are available, so we can definitely say it is bacterial or viral, and we can go with that. And other thing is loose stools. Usually the babies come with 1 or 2 days of loose stools, which will be of viral mostly. And only indication for antibiotics in loose stools is bacillary dysentery, that is shigellosis. So those conditions we have to treat with antibiotics. Otherwise, we don't need any antibiotics in them. The next thing is local infections like skin infections, like pustules are there. Even in newborns, less than 10 pustules, small pustules, is that you don't have to have systemic antibiotics. You can give local antibiotics itself. Conjunctivitis, even if it is purulent, except for gonococcal conjunctivitis, you don't need much of systemic antibiotics. And if you see, so eye infection, ear infection, skin infections, other thing is urinary tract infection. So these are the common conditions the babies present to us in OPD. So other than those things, babies don't need any antibiotic prescriptions.
Thank you, ma'am, for this elaborate coverage. And the next question comes, after how long an antibiotic should be reviewed for change in pediatric?
Yes. Before even we think of changing of antibiotics, we have to consider the 4 Ds. I am emphasizing here, Dr. Puneet has already told that we have to take care of 4 Ds, that is right drug. Is this antibiotic suitable for this condition? And is the dose we are giving? Mostly in pediatrics, we give the dose based on the weight. So we have to think whether this antibiotics we need a peak concentration level or steady state level of antibiotics. So the drug, dose and duration of antibiotics is very, very important. And after that, we have to de-escalate. The 4th D is de-escalation. Once the baby is sick, we give antibiotics for 48 hours. Definitely there should be a timeout of 48 hours to 72 hours antibiotic timeout to review our prescription, even in ICU patients. to prevent misuse of antibiotics in causing antimicrobial resistance. So definitely 48 to 72 hours is the time required for changing antibiotics, that too with adequate lab investigative support saying that this is a bacterial infection which needs warrant of another antibiotics. Unless we have a diagnostic test, we don't know where to go about. So definitely before change of antibiotics, we have to take a blood culture depending upon the site and system involved. We have to take cultures and rapid diagnostic test as early as possible, and sensitivity. It will help us in, one is de-escalating antibiotics and reducing the cost to the patient, and for the patient to have from IV to oral switchover. Thank you.
Thank you, ma'am. Ma'am, one last question for you. Do the use of antibiotics in neonates confer any long-term sequelae in them?
So usually we think in NICU antibiotics are used very commonly because they are more immunocompromised fellows. So even they get antibiotics from the mothers, intrapartum or peripartum antibiotics. Even 1 or 2 doses of antibiotics, either intrapartum or peripartum in the mother, also affects the gut microbiome establishment in the newborns. So even 2 doses of antibiotics in newborns is going to affect their gut microbiome. So they are going to have gut dysbiosis, where the microbiomes, there is no much of diversity of microbes are there. So all the normal commensal microorganisms are going to get lost. The pathogenic organisms is going to get colonized. And this in turn have a long-term sequelae in terms of metabolic diseases like metabolic syndrome, obesity, diabetes mellitus, allergy, asthma, cancers, inflammatory bowel disease, autoimmune disease like multiple sclerosis. Even for us to live, how long we live is actually determined this gut microbiome, the longevity of the human individual. So these are the long-term sequelae which even don't even think of when we are prescribing antibiotics in NICU especially. We think 1 or 2 doses, what is just going to cause harm to the baby? We are actually saving the babies by giving antibiotics. So we have to think of this long-term sequelae, keeping in mind this. Yes, ma'am.
Thank you, ma'am. Thank you so much.
Thank you so much, ma'am.
I now welcome Dr. Anita Saran, Assistant Professor in the Department of Anesthesiology, for the panel discussion. Joined us. Kindly unmute yourself. Yeah. Welcome, ma'am. So the first question that I want to pose to you is, our audiences wanted to know, so what are the drugs used for surgical antibiotic prophylaxis? Why are they so used? When the antibiotic surgical prophylaxis should be given? And what are the situations in which a standard number of doses should be increased?
Hello, everyone. First of all, I would like to thank you and congratulate the entire microbiology department of Aiims Bilaspur to conducting such an instructive and enlightening CME on antimicrobial stewardship. So coming back to the question first, so it has got 3 components: what, when, and why for surgical antibiotic prophylaxis. So I would like to answer first why we need to give surgical antibiotic prophylaxis. As we all know that surgical site infections are one of the potential complication of any surgical procedure. And it is not only that, it is also one of the most preventable among all the hospital-acquired infections. So definitely we need surgical antibiotic prophylaxis. So generally when the surgeons prepare the surgical site, the resident flora in the deeper layer of the skin are not taken care of by antiseptic or antimicrobial solution. So to take care of that and the transient flora, we need to give antibiotic prophylaxis. Now, when we have to give this antibiotic prophylaxis during the surgery, is the best time to give it is before surgical skin incision, and that too within 120 minutes of the incision. So around 60 to 120 minutes is a fair time to give antibiotics. Now, what are the drugs which we can give as surgical antibiotic prophylaxis are generally, there are no such guidelines that can say this antibiotic is to be given during this procedure. But if we talk about guidelines and literature, so bactericidal, which can give a good coverage for the a good 1 to 2 hours, can be given as surgical antibiotic prophylaxis to say that first generation cephalosporins, cefazolin is a fairly used drug to to give a good coverage. And what are the situations in which, okay, so generally a single dose before incision takes care of the surgical site infections, but there are few situations where you might need to redose, and one of which is if the surgical procedure exceeds more than 2 half-lives of the antibiotic given, then you have to repeat the dose. And if we expect or there is a massive blood loss, say more than 1.5 liter in adults and 25 ml per kilogram of blood loss in children, in that situation also we have to give a repeat dose of antibiotic, and we have to repeat before the wound closure.
Thank you, ma'am. Thank you for this insight. Ma'am, what are the guidelines available for the same? What are the references we are talking about?
So up until 2016, there was not much written about surgical antibiotic prophylaxis in a consolidated form. But in 2016, WHO has come up with recommendations for prevention of surgical site infection, in which 29 recommendations are given. And out of 29, four are talking about your antibiotics. So one is WHO guidelines and then other one is NICE guidelines. I stumbled upon ICMR guidelines also, but which are exactly the replica of WHO guidelines.
Thank you, ma'am. Thank you so much. We now move on to our next panelist, Dr. Deepak Sharma, Associate Professor, Department of Medicine, Aims, Jodhpur. Sir, please join us.
Yes.
We welcome you, sir.
Thank you.
So the first question that I want to pose to you is, yes, sir. So what are the fixed drug combinations that are being rampantly misused in our country?
Firstly, I would like to thank Anuradha ma'am for inviting me for this CME and discussion. And for the question, what is the fixed drug combination are being rampantly misused? I think in the latest study which is published in the PLOS, and they have analyzed this FDC antibiotics in 75 countries, and they found that out of 119, the 80 FDCs are belong to the India only. And India has a lot of FDCs almost in every segment of the drug. If we are talking about the this antibiotic, this cefixime, dicloxacillin, lactic acid bacillus, meropenem sulbactam, cefuroxime, linezolid, cefixime, levofloxacin. There are a lot of FDCs are available, and they are used rampantly, very much in country, and most of them, more than 60%, are even not authorized by this our CDSO, or even very few FDCs of antibiotics were authorized from the this FDA. So there's a lot of FDCs are available, and this cefixime, levofloxacin, cefixime, azithromycin, and cefixime dicloxacillin, there are irrational. These FDCs are used rampantly. So there are some FDCs are very useful, like trimethoprim sulfamethoxazole, we are known as cotrimoxazole, or amoxiclav, or we are recently launched this new NTP guideline. We are using FDC for the treatment of the tuberculosis. We are using the FDC as in the form of antiviral for the treatment of the HIV and hepatitis C. So these are useful and approved, but along this 80% of FDCs are not useful and not approved in India.
Thank you, sir. So the menace of fixed drug combination is large. But so what are the alternatives? What do we do then?
I think there should be require a awareness about the use of the FDCs, and the most important hurdle of regarding this misuse of FDC and to think the alternative that there's a lack of awareness in the physicians. Just a one pharma company and go and say that sir we can use we have this combination of drug and we can use in this situation, we can use this situation, and most of the practicing physician are or clinician are not going to check the guideline, and they are using frequently this FDC. I think if we require to use the FDC, we should check available guidelines and literature before using. And otherwise, without knowing the exact guideline and the literature, we should not use. So there is a require of the some policy implementation from the government to use of the FDC. There's a require of frequent awareness programs in the clinician regarding the use of antibiotics and FDC in the various situations. And there should be required regular stewardship program in almost every medical college level, so they can prepare a leadership to use of these fixed drug combinations in their areas.
Thank you, sir. So, sir, in today's CME, we discussed that stewardship is required for antibacterials, for antifungals. But what about anti-malarial, sir? Please, could you help us out there?
Yes, definitely. Definitely, the stewardship is required for anti-malarial program. And what are the main reason why it is required? First, the diagnosis of malaria is much easier than the diagnosis of the bacterial infection. So most of the time, these rapid diagnostic methods are not using in even the peripheral area, and they are directly giving the anti-malarial drug. And this directly giving anti-malarial drug lead to the unnecessary selection of the pressures over the parasite and lead to the resistance. And if there is no stewardship, the maximum of time they are underdosing. Again, this underdosing further lead to the resistance. Secondly, if we are not using the anti-malarial without proper stewardship, they lead to the unnecessary toxicity. Again, like G6PD deficiency, it is not an uncommon in India. And if we are using rampantly the anti-malarial, that unnecessarily increase the toxicity and lead to the fatal complication of the patients regarding anti-malarial drugs. So I think it is necessary and it should be even hospital and community-based stewardship should be done for anti-malarials.
Thank you, sir. Thank you so much for joining us, sir. Thank you. We now move on to our next panelist, Dr. Sushruti Kaushal, working as Assistant Professor in the Department of Obstetrics and Gynecology at Aiims Bilaspur. Ma'am, please join us.
Yeah, good afternoon, Dr. Megha.
Welcome, ma'am. So, ma'am, the first question that I want to project to you is, why amoxiclav should be avoided as surgical antibiotic prophylaxis for an elective cesarean section? We know it is being used right, left, and center, but what do you suggest?
Yeah, thank you. And firstly, I would like also to thank Dr. Anuradha ma'am specially for taking this initiative in antimicrobial stewardship and for giving me this opportunity to be a part of it. Coming to the question, amoxiclav is routinely, very commonly, not routinely, but commonly used as an antibiotic prophylaxis for cesarean. But there are studies that show that use of amoxiclav has been associated with high incidence of necrotizing enterocolitis, especially in preterm babies. So the studies are do not show increased risk with term babies, but still it is probably safer. And according to guidelines also, WHO also says the same. It is probably safer if we do not give it for term pregnancies also. So to prevent necrotizing enterocolitis, to prevent the increased risk of enterocolitis, necrotizing enterocolitis, we should be avoiding this antibiotic and we should go with first-line cephalosporins, as Dr. Anita said. Cefazolin remains the first-line treatment, first-line antibiotic prophylaxis.
Now there is a question from the chat box. How long should we give surgical antibiotic prophylaxis post-operatively after cesarean section? See, for any surgery, for any clean contaminated surgery, the surgical prophylaxis is only of single dose. Okay, if surgery gets prolonged beyond the half-life of the antibiotic, then we need to repeat the dose. Or if there is massive blood loss, then we need to repeat the dose. Otherwise, this prophylaxis is when we give the in season. So from the deeper layers of the dermis, whatever resident commensal flora, which is usually staph, which we want to eliminate, antibiotic prophylaxis is given. And remember, these drugs are, what are these drugs? Cefazolin, first generation cephalosporin. So usually SSI or post-surgical infections will occur because of MDROs. And this antibiotic is not going to take care of those MDROs. And in all patients, SSI is not going to happen. So what is to be done? After this surgical antibiotic prophylaxis, no antibiotic should be given, and maximum up to 24 hours if you feel that there was some, misstep, or there was asepsis was not completely done. So what is to be done is, when any infection occurs, do the culture sensitivity, and according to sensitivity and the isolate, appropriate therapy should be given. Okay, this prolongation of surgical antibiotic prophylaxis is not going to prevent SSI. Okay,
and
thank you.
Can I add on something, ma'am?
Yes.
Ma'am, according to ACOG, the American Congress of Obstetrics and Gynecology, they do give one indication of continuing antibiotic beyond cesarean section, and that is in obese patients, where they mention in high-risk patients, only the obese ones, they benefit from adding a cephalosporin for 5 days post-cesarean, where the surgical site infection risk decreases more than the single-dose antibiotic prophylaxis that we routinely give in all other situations.
Wonderful. Thank you, Sushruti.
Thank you, ma'am. Ma'am, the next question is, vaginal discharge is an important OPD symptom in gynecology. So, ma'am, what are the misuse of antibiotics in this particular condition?
Yes, antibiotics are very commonly misused in vaginal discharge. The first problem starts with the patient's perception. See, the patients believe that vaginal discharge is associated with many diseases. There are many myths associated with vaginal discharge, that it causes cancer, it causes weakness, that it will dissolve away your bones. So even thin or young girls with low BMI will be coming to a gynae OPD with complaint of vaginal discharge because they are not gaining weight. And most of the times they will be having a physiological discharge. Similarly, many females of any age group will be coming with a physiological discharge, which is actually required, physiological discharge for lubrication of vagina, that is, they are having an abnormal discharge and need treatment. And it has become increasingly common that the doctor also, and maybe they are taking the medicines from over the counter from chemist also, will give an empirical treatment combining all the causes of vaginitis and cervicitis that would probably cause discharge and treat them. So whenever a patient with a vaginal discharge comes to us, first we should start with the thorough history taking, which should include the risk of sexually transmitted infections, any high risk behavior. Then examination, which would include a per speculum examination for the type of discharge, bimanual pelvic examination, and it would be very good if we do a canine smear examination of a high vaginal swab, which can tell us about candida and bacterial vaginosis especially. So 2 things we can diagnose right there. And in addition to that, WHO now says that where facilities are available, we should do molecular assays or a rapid diagnostic test for 3 organisms, which would be Candida, not Candida, Chlamydia trachomatis, Neisseria gonorrhoeae, and Trichomonas vaginalis, and treat according to whatever results we get, if based on the presence or absence of these organisms. In situations where neither the molecular assays nor rapid tests are available, we should base our treatment at least on the per speculum examination. If we see cervicitis, we treat for causes of cervicitis, which would be chlamydia and Neisseria. And if there is no cervicitis, we do not treat for it and treat based on the color or consistency of the vaginal discharge. And even in these patients that we treat empirically, if they do not respond completely to first-line treatment, we should be going with sensitivity and susceptibility testing, because even these organisms like Trichomonas vaginalis is showing resistance to the first-line treatments now.
Thank you, ma'am. Thank you so much. Now, with this, I conclude the panel discussion. I'm grateful to all the eminent speakers who have joined us for the panel discussion and who have thrown useful insight from their clinical experiences. Next, we have a presentation from our star sponsors, the Thermo Scientific company. But on the other side of the presentation, the quiz results are waiting for you, and so is the answer key for the quiz. So stay tuned.
Good afternoon, everyone. And can you please put it on the slide mode?
Yes, Kajal, can you hear us?
Yes, ma'am.
Your presentation is on air. Yes, please.
Yeah, but I don't see the slide mode, ma'am.
Kajal, we can do one thing. You can request the person next. Okay, so because he'll be having the rights for the slide control.
Okay, thank you, ma'am. First of all, very good afternoon, and thank you, Aiims, for providing us an opportunity to present our product presentation. And I welcome all the delegates. From Thermo Fisher Scientific, myself, Kajal Bhatt, I'm the marketing manager taking care of South Asia microbiology business of Thermo Fisher. So we would like to present a short presentation on product portfolio of Sensititer AST system. Please go next. So Thermo Fisher is having a rich history of microbiology excellence with a unique heritage in our service dedicated to microbiology with the brands Oxoid, Ramel, and Trek. We present a larger portfolio for culture medias, antimicrobial susceptibility testing by manual or by automation method, also along with some of the basic manual latex agglutination testing. Please go next. So we provide a complete solution to have a confidence in better patient management with the antibiotic DIS, the broad dilution method, the quality control strains. These are 80cc strains, and also along with the culture media for the general and the chromogenic use. Next, please. So when we talk about the antimicrobial susceptibility testing, we provide a solution which make the AST easy with the accurate and scalable automation for the wide range of organisms. I would like to play a short video which will put more lights on our solution.
Backed by 150 years of combined scientific expertise, Thermo Fisher Scientific has become the global partner of choice for today's leading microbiology laboratories by helping clinicians and veterinarians deliver healthier tomorrows for the critically ill. Trusted by a growing network of healthcare professionals, the Thermo Scientific Sensititer AST system offers both flexible, manual testing options or the time-saving benefits of automation, including our latest instrument, the Thermo Scientific Sensititer Aiims HiQ system.
To be able to get an accurate measurement of MIC for very specific drugs like vancomycin, for me, is wonderfully valuable.
With antibiotic resistance on the rise, it's more important than ever that microbiology laboratories determine susceptibility with the most accurate methods available. The Sensititer system delivers minimum inhibitory concentration, or MIC, results, a vital measure of antimicrobial effect to better support successful stewardship efforts. With a full range of off-the-shelf plates for routine testing, as well as niche applications like yeast, fastidious, anaerobes, and mycobacteria testing, the Sensititer system provides access to over 300 antimicrobials. 4 custom formats, users can order and receive custom plates in just a few weeks with our simple design process. Easily combine results from manual and automated read options and consolidate your entire testing program with the benefits of LIS connectivity using the Thermo Scientific Sensitizer SWIN software. From accurate order placement and successful installation to thorough training, our customer service and 24-hour technical support teams are with you every step of the way. Comprised of flexible, scalable instrumentation options to support microbiology workflows, the Thermo Scientific Sensitizer AST system provides clinicians across the globe with a comprehensive AST result that guides more targeted patient treatment. To learn more, visit thermofisher.com/sensitizer.
Next slide, please. So Sensitizer AC system, we provide the flexibility to operate it manually or semi-automated or fully automated way. So this gives a flexibility to all the kinds of laboratories with a higher volume or low volume or having any other systems, and to add up the complete profiling of the panels. Please next slide. So the solution is a scalable instrumentation. You can keep on adding the instruments as and when you want, or else you can go ahead only with the panels to perform your AST profiling with the visual results also. So in the scalable instrumentation, we provide nephrometer to perform the turbidity check. Then auto inoculator, you can either use the pipette single channel or multi-channel. Or you want a more accurate inoculation, we have this AIM instrument for the inoculation of the culture into inoculum into the plates. Then we have a vision and opti-read systems. Now these systems are based on either the digital scanning or the fluorescence reading of the panels to interpret the results. Along with that, we have Aiims HiQ system, which has an inbuilt incubator along with the fluorescence-based reading. These all three systems are connected with the SWIN software, which is an expert software to provide interpretation, and along with the it is updated with the CLSI and UCAS guidelines. So it gives the flexibility to use which guidelines you want to go ahead, and for any isolate you can perform the interpretation. Next slide, please. So when we talk about the standard plates of AST panels, there are standard formulations available, and also for the research purpose, you can customize the panels for any new antibiotics. We have more than 300 antibiotics on board. The sensitizer will provide true MIC results. So there will not be any calculation, but whatever the results are giving you, you are getting the results for the particular isolate that you are going to report it out. So this will provide a real scenario of the resistance of the isolate under the testing. And with this, it is based on the broad microdilution method. So it will give you definitely a high reproducibility and sensitivity. We have multiple formats available in the single or multi-isolate format. The results will take 18 to 24 hours. And it can be read visually or with the digital or fluorescence method using our vision or opti-read system. Next slide, please. So we have various panels which will cover gram-negative, gram-positive, fastidious, yeast and molds, mycobacteria, non-mycobacteria, also for the veterinary use or surveillance studies. And also you can customize your panels as per your requirement of the concentrations and the drugs of interest. Next slide, please. So when we talk about the sensitizer, the unique capabilities are, it is based on broad microdilution method, which is a gold standard method. It will provide you a true MIC with the latest antibiotics on board, and there is no logical interpretation. It will give you the real scenario. The MIC will be in your hand to interpret. We have very special panels which are already being in use at multiple centers in India. Few panels are fungal panel with the 9 drugs. Then for non-tuberculosis, that is separate panels for rapid and slow grower non-mycobacteria. We also have TB panels for TB bacteria with the primary and secondary drugs, and also for the research purpose with the latest drug delamide and bedaquiline. Also, we have panels for colistin, polymyxin, ceftazidime combinations. The panels are FDA approved. It has a global acceptance, and with very small footprints, you can perform a broader range of antimicrobial testing for your routine or for the research testing or for the surveillance studies. So it is fit for all kinds of workload from low to low, high workload. Next, please. Next slide, please. So from many years, the sensitizer is a partner in battle against the antimicrobial research, and it is not only being used into the clinical studies, but also into the veterinary, pharma research, and all the offline clinical testing. Sensitizer is also the highest quality provider to offline testing market for fastidious, antifungal, and the new drugs, or the customized AST for multiple pharma projects, the the clinical trials, or the pharmacovigilance studies and all. Sensitizer is also considered as a standard surveillance tool into many of the projects like US CDC, NARMS, and Denmark projects. So it is already a global partner in identifying the antimicrobial resistance or the new resistance which are getting developed with the new antibiotics in place. We have all the antibiotics on board. We have various tie-ups with the pharma companies so that we can provide you the solution to have the testing solution available at your end. With this, I will end my presentation. Thank you very much. We look forward for your support. And if you have any queries, you can anytime reach out to us through Thermo Scientific. Thank you so much.
Thank you, Thermo Fisher Scientific, for the illustrative talk. Thank you. We now move on to the last leg of the CMA today. I request Ma'am Dr. Anuradha Sharma to kindly share the answers of the quiz first, so that the audience are still kept updated and they can think over whether they have won or not. Over to you, ma'am. Mr. Herschel, please let ma'am share her screen. Till we get access to ma'am, let me tell you that it was such a wonderful participation from you all. There were more than 80 participants for the quiz, and it was higher than what a national, even conferences do not generally have this much of attendance on a quiz. So let's head towards the answers now. Over to you.
In my audio. So I think everybody was so excited about this part of the event, and my source has been Oxford's Handbook of Infectious Diseases and CLSI 2021 guidelines. So the first question was, the biggest misuse of antibiotics is in growth promotion in animal husbandry. Okay. Then drug of choice for intrapartum UTI is, answer is cephalosporins. Then seizures and nausea can occur due to too fast infusion of imipenem, and therefore imipenem is never used in cases with CNS involvement. Cholestatic jaundice can occur due to clavulanic acid, so therefore we don't give amoxiclav in pregnant women. It increases the chances of jaundice in newborn. Escapum organelle, that is Enterobacter, Serratia, Citrobacter, Acinetobacter, Pseudomonas, Proteus, Providentia, Morganella. These are spice-based scapum organelles which have inducible MC beta lactamases. Very important to look for these. So they develop inducible resistance due to use of second or third generation cephalosporins. We must not use them. Then all are true regarding therapeutic drug monitoring of following drugs except for. So we do TDM for vancomycin before the third dose and for teicoplanin after 7 days of treatment, and for voriconazole to prevent hallucinations and visual disturbances in the patient. Okay, so therapeutic drug monitoring is another very important area coming up, and we should have provision for that. Then which of the following has best bone tissue penetration? So teicoplanin is the drug of choice among all these. Then in 2021, fidexomycin has been approved as the first line of therapy, but for CSAI, vancomycin remains the drug of choice. Why fidexomycin has been approved? Because it prevents the recurrence of the infection. Then in a case of uncomplicated UTI due to Enterobacter colici, lab should withhold report of sensitivity of which are third generation. It is similar to question number 5. It's a very important issue. You must realize this, what is cascade or what is selective reporting and why it's important. Then a susceptible dose dependent report for cefepime for Escherichia coli infection means all. That is, either you can increase the dose or you can increase the frequency or you can do both. Then in a follow-up culture to look for emergence of inducible resistance should be done in following scenarios except for. So last is the answer, but for Pseudomonas, it's known that it can develop resistance to all the possible antimicrobial agents. Staph has a tendency for fluoroquinolones and Klebsiella for third generation cephalosporins. Then question number 12 is which drug bug combination should be not reported by the lab? So we know Salmonella typhi, aminoglycosides have no role, even if they show sensitivity. Then for enterococci, clindamycin, cephalosporins, cotrimoxazole, all 3 C's have no role. Then in CSF isolates, imipenem, because it has a side effect as seizures. So then in 2021, CLSI has removed susceptibility breakpoints for colistin. They have only given intermediate and resistant. Okay, the prolonged intravenous infusion are given for all because we have to. These are concentration time dependent antibiotics. They are not concentration, whereas amikacin is concentration dependent antibiotic. So it needs a single proper dose according to body weight. Whereas all carbapenems, okay, they are time dependent. So prolonged infusion should be given in these drugs. Then colistin has very poor penetration despite systemic administration in all lungs, bones, CNS. Therefore, it's given intrathecally in brain, in lungs by nebulization. MRSA is resistant to all. So yes, once methicillin resistance means it is resistant to all beta-lactams, including beta-lactam BLI combinations. So ceftaroline is the 5th generation cephalosporin, which is especially effective against MRSA. In a case of brain abscess with anadrose, patient is receiving treatment with clindamycin. Now, which antibiotic should not be added because of overlapping spectrum? So we must know that when we are giving amoxiclav, imipenem, or metronidazole, so they all take care of the anaerobic infection. We don't need to add any other that is, as ma'am mentioned in the morning, Nusrat ma'am, redundant antibiotic. You are unnecessarily wasting the antibiotic to give another coverage for the anaerobes. Then how many doses of antibiotics change the gut microbiome? Even a single dose of a broad spectrum antibiotic with a good coverage of microbes is capable of altering the microbiome. Then all are collateral damages produced by antibiotics except patient dissatisfaction. Of course, you know, people prescribe, especially in private, that okay, patient will be happy that okay, I'm under the coverage of antibiotics. So that is not a collateral damage and we need to take care of that. Then ideally following drugs should receive prior authorization from antimicrobial stewardship team to be used beyond 1 day. So, you know, in my lecture, I've talked repeatedly that this empirical therapy is to be used only for 24 hours. By then, you should have report of AST, and depending on the AST, you have to escalate or de-escalate the therapy. Then weekly LFT monitoring is required with following drugs except for. So you should know that vancomycin has nephrotoxicity, but all this ceftriaxone, etapinum, meropenem, they are capable of deranging LFT in a patient. So it should be monitored weekly, and therefore ceftriaxone is not used in neonates. All our indicators for prescription audit except, so ma'am has covered this in the morning, so daily defined dose, days of therapy, antimicrobial free days, they all are used except for TDM, and you must know what is TDM. Antibiotic time out is, so it is both A and D. It is a period of 48 to 72 hours to review the response, and after the empirical therapy, targeted therapy is started according to the sensitivity report. Then which of the following is not a true pathogen? So Candida from a wound swab. Candida is a commensal from the skin. So it will grow in the moist, warm condition of the wound. So never report it. You know, it's not a pathogen there. Enterococci from a bowel sample. It doesn't produce any lung pathology, and it's a commensal from the upper respiratory tract. Then cons from a blood culture after 24 hours. See, all true pathogens will grow around 11 to 12 hours, less than 20 hours. With automated systems, it is within 12 to 14 hours. So anything growing, and especially cons beyond 24 hours, it's a contaminant from the skin. And which fungal infection behaves like a MDRO and can cause high mortality in a hospital is Candida auris. So it was wonderful experience of sharing this quiz. Now I will announce our today's quiz winners. Okay, stop sharing, and okay. What? Sorry, I can't get it. Unmute and video, no? I'm visible.
Ma'am, you're visible and you're unmuted. Kindly share us the results.
Okay. So the fifth prize goes to Dr. Jasbir Singh Roy, Assistant Professor, Lakhampur Medical College, Assam. Thank you, Dr. Jasbir. It was really joy to have you from Northeast. I'm so proud of that. And we were really thrilled and excited and encouraged by your participation. Then fourth prize goes to Dr. Archana Garg, resident from GMC Kota. Congratulations, Dr. Archana. I remember you. Then third prize goes to Dr. Mahvish Javed, microbiologist from Ministry of Health, Kingdom of Saudi Arabia. Dr. Mahvish, you had asked me in the beginning only when I showed my first flyer, ma'am, when is registration starting? Thank you so much for participating. I'm so happy and thrilled. One international participation, wow. Then second prize goes to, wow, my dear Dr. Parvati, my old junior resident. Now she is a senior resident in Aiims, Kalyani. Parvati, I am always so proud of you. Congratulations, dear. You deserve it very much. And first prize goes to Dr. Soman Saha, consultant clinical microbiologist, Medica Super Specialty Hospital. Congratulations, Dr. Soman Saha. Wonderful. You have made us so proud. You are really at it. You are, I think, not only a winner of this quiz, but you are really doing your work very with a lot of dedication and passion. Congratulations.
Many congratulations to all the winners. At the end, I request Dr. Prashant Sood, Additional Professor, Department of Microbiology, please come forward and give the vote of thanks. Please, sir.
Thank you very much, ma'am. Thank you for giving me the opportunity to express the gratitude to all the participants and all the members. First and foremost, I would like to profusely thank and express our deepest gratitude to our Honorable Executive Director, Professor Veer Singh Nehi, and our Honorable Dean, Professor Sanjay Vikrant, for their invaluable patronage and support in helping us organize this first nationwide CME by the Department of Microbiology, Aiims Bilaspur. We express our immense gratitude to Professor Pallav Ray and Professor Anuradha Sharma for their scientific insight and vision, without which this CME would not have been possible. It has been a great honor that doyens in the field of antimicrobial stewardship and antimicrobial resistance, including Professor Pallav Ray, Professor Aarti Kapil, Professor Nusrat Shafi, Professor Anuradha Sharma, Professor Shiva Prakash Rudrabhuti, Professor Manisha Biswal, and our own experts, Dr. Puneet Gupta, Dr. Megha Sharma, Dr. Yangshin Lamo, have graced this event, given their valuable time and shared with us their years of invaluable experience and insight into the pressing problems of antimicrobial resistance and antimicrobial stewardship. We are immensely grateful to our expert panel of Dr. Deepak Sharma, Dr. Darwin Kaushal, Dr. Chitresh Kumar, Dr. Nalini Aswathaman, Dr. Anita Saran, and Dr. Sushruti Kaushal, who brought to the fore through their thought-provoking discussion the practical problems and ground realities of antimicrobial resistance and stewardship that the clinicians face every day and how they tackle them. This CME would not have been successful without the resounding support and participation of our numerous delegates, amounting to nearly 300 from across the country and even abroad, and our own faculty from Aiims Bilaspur. We thank you all for joining us today and making this CME so worthwhile. We thank you for so actively participating in our quiz, and we congratulate not only the winners, but all of you for making this interaction so exciting. We would also like to express our warmest gratitude to Ms. Mayanka and Ms. Kejal Bhatt from Thermo Fisher Scientific, who have lent their invaluable support by sponsoring this event. No event of such magnitude can be successful without the tireless efforts and support of our events and organizing team. We would like to profusely thank Mr. Nitin and Mr. Bharat, our event managers, and Mr. Hemraj from Aiims Bilaspur, our accounts officer. We would also like to profusely thank Professor Anuradha Sharma, Dr. Megha Sharma, and Dr. Swati Gupta for their tireless efforts to iron out every detail of the event. And Professor Pallav Ray, Professor Anuradha Sharma, Dr. Megha Sharma, Dr. Swati Gupta, and Dr. Yangshin Lamo for their insight in crafting the scientific contents of this event. In the end, we would like to thank everyone who has contributed to this timely and pertinent event, and we sincerely hope that you have found it useful and thought-provoking. We hope to meet you soon again. With best wishes and warm regards.
Thank you so much, sir. With this, we come to the conclusion of today's CME. Thank you all the participants, delegates. Thank you all.